All right, welcome back to the Hurwitz Lab. Hey, Alan.
Hey, Craig, how you doing?
I'm doing well. I'm excited. Every time we get together and we pick one of these talks and you give me the topic that we're going to work on, I always think this is the one. This is epic. And this blood pressure talk, wow, I'm really excited about today.
I'm pretty excited, I got to say, because I think that, we're going to go a little bit beyond, our other talks have been a little bit on philosophy. This one's going to be more on philosophy. This is a pretty big topic, blood pressure.
And I think clinically it's massive. I mean, as a busy nephrologist, it's a big part of what we do every day.
Right. So because the topic is so big, I have constrained ourselves today. We're only going to go from ancient China to the end of 2021.
I love it.
That's it. I can't, that ancient China to end of 2021, and that's all we can do today.
And I think there's so many questions here that, as we discuss this topic, that come up both from a management standpoint, but from the hypothesis of how does pressure work. And we had this whole talk on flow that you gave.
Yeah.
That was awesome. And the more you know, the more questions keep coming up.
That's right.
And I think this raises a lot of interesting questions.
Right. So today we're going to talk all about blood pressure and also bring in some philosophy because of Plato's Allegory of the Cave we're going to get to. And what today's talk is going to actually, again, just as it happens, we've got the order making some logical sense here because we're going to cover stuff today that have to do obviously with salt, obviously with flow, and obviously with the sodium transport we talked about last time. So it really builds on a lot of, you'll see some old slides, which is good to call some of those back. But today is all about blood pressure. And so if you're ready.
I am ready. Let's get
started.
Into this.
So it's all about blood pressure, and on there's going to be some stories here. So here's a famous picture from Yalta where you have Churchill and some other guy, and then FDR. And here on the right is just showing what we're talking about today. So here, if you go from the aorta all the way through the circulation, what you see here is this up and down red. Well, this is the systolic and diastolic pressures. This is the mean arterial pressure. And the difference between these two things are the pulse pressure.
Exactly.
And you can see all the action takes place. The big action here where the derivative is big is all going on through arterioles, as we've talked about before. So it's a high pressure system leading to a low pressure system. And this is just my opinion. I think that as an engineer, systems do not like high pressures. I mean, high pressure systems and high voltage systems, those are driving forces, have to be labeled danger, high voltage, danger. So for the body to develop a high pressure system, must have been some decisions made because that is risk. Because if there's the hole, I mean, look, what do you run your patients on dialysis? What's their blood flow rate?
Yeah, blood flow rate will be like 400 or 500.
500
milliliters per minute.
Okay. And so how long, if one of those needles comes out, how long until they're in shock?
Yeah.
Yeah. I mean, 500 mils a minute.
Yeah. It's pretty quick.
Your whole blood volume's,
5 liters.
Well, less. So it's shocked pretty fast. So, these are dangerous systems and they have to stay closed. And so we'll talk about blood pressure, but don't forget, blood pressure is something, as we've talked about before, driving forces are easy to measure. And the question is, do we measure blood pressure because it's very important physiologically and that's the mechanism, or do we measure blood pressure because it's easy to measure? Okay. So before we get into that, I wanted to talk about, in terms of the history of hypertension, I looked at some top areas for medical publications. This was just put on line. And it goes over in each year, what were the top number of publications, on certain diseases. So here what you see, back in 1947, where this starts, look at the top 3 diseases of peptic ulcer, which is certainly, since the, a Nobel Prize for PPIs came out and we understood more about the bacterial infections in the Heliobacter, right?
Right.
So peptic ulcer is kind of an infectious disease, and TB and malaria and polio are all things. Hypertension was number 6 in 1947. Now, 1980, hypertension jumped to number 1. Look at that. And you can see everything's vascular. Hypertension, coronary artery disease, heart attack. And then the cancers get in there. 1990, hypertension drops to number 2 because of the AIDS epidemic.
Right.
And again, you still see infections and heart disease and cancer. By 2010, 20 years later, only about 12 years ago or 11 years ago, the cancer and HIV and obesity has made into the list, and hypertension's dropped to 6. In 2019, hypertension's off the list, and you've just got cancer, HIV, and diabetes is on the list, along with stroke. So it's cardiovascular infections and diabetes. And then something interesting happened in 2021, Craig. Look at that. So all of a sudden, everything is dwarfed.
Yeah.
I wonder what
all all attention went to what was causing a massive pandemic, right?
Right. So COVID-19 publications, look what it did to all the rest of the publications.
Right. Just dwarfed it.
You just can't see it on the scale anymore.
But something did happen because there have been so many publications that have been withdrawn. There's been so much controversy over different studies because there's something happened to and I think that's going to happen because the floodgates open for people to report findings.
Exactly.
But that's super interesting.
So what explains why hypertension was not on the list in 1947 hardly, that was 6, and then became number 1 by 1980, and now it's dropped off again. There's a reason for that, and hopefully you'll see with what we present today, how this timeline matches up with the timeline of the history of hypertension. So, starting back with FDR, so he lived from 1882 to 1945. He was only 63 when he died, and he was the president for like his whole life. So he was the only person to serve 3 terms, and unfortunately, suddenly,
out of nowhere,
on April 12th, 1945, out of the clear blue sky, Craig, the president's physician says, out of the clear blue sky, a blood vessel broke in his brain. Blood vessel broke. I love that. I don't love it, but that's what they said. So that's the last known photograph of him. But let's see. It was came clear out of the blue sky, Craig.
That's what I heard.
So his last words were, and he was a chain smoker, and his last words were, "I have a terrific pain in the back of my head." And it was April 12th that he said that. And 15 minutes later, his doctor measures blood pressure, the highest blood pressure I've ever seen, 350 over 195. Pretty high.
That's high.
Of course, using probably
a stig.
That's
stage 2 by current guidelines, isn't
it? it's probably stage 11 to million.
Yeah, it might be hypertensive urgency.
So it came out of the clear blue sky, as you can see. So here the poor guy's got proteinuria, and we already know that proteinuria is a marker of endothelial unhappiness. Now, we happen to see it because the kidney makes urine, but proteinuria of the glomerular capillaries is unhappiness of blood vessels everywhere. I think the kidney is the canary in the coal mine that tells you that.
Exactly.
He's got LVH on his EKG, and then he had a couple of mildly stressful events. D-Day, election.
Just a few.
Yalta,
he came in, he was talking to his doctor about him. He's like, I had a rough week.
His doctor says, what's wrong? He goes, well, depression. He goes, you're depressed? He goes, no, the depression.
That's good.
FDR had depression.
I'm feeling down. No, it's the depression.
The depression.
That's so funny.
I'm not talking about mine.
Right.
So and he had other things to worry about.
That's classic.
World War II and all. And winning World War II. And that picture I showed, it was Yalta, his blood pressure was clearly already, this is 250. So he was hitting the 250s on a regular basis. And this is, of course, the last day when he was 350 over 190. So I don't know what they mean out of the clear sky.
Right.
When you look at this record. I mean, he was a time bomb.
Exactly.
So,
it's amazing he went so long.
Well, and if you look at pictures of him, he looks unwell.
Yeah.
And people probably just thought he was sleep deprived and stressed, but he was vasculopathically not good. Okay, so he could have really used what I take, chlorthalidone and losartan, as we're going to see. Okay, he could have used those. So here's our outline for today. I'm going to go over a little bit of the evolutionary physiology of blood pressure. How did blood pressure come about? We'll look at the clinical history of hypertension. Have you ever seen a patient with hypertension?
Yeah, I've a couple.
A couple, okay. So you're a country doctor.
I'm a country doc. I see a few.
Case a year.
Yes.
And then we're going to talk about something that's a little bit of an interesting and somewhat controversial topic: the physiologic basis of blood pressure, because nobody really knows. It's a mystery. It's kind of a black box.
This is my favorite section.
Yeah, it's a great section.
Great.
Then you're going to give us, we're going to talk about the clinical approach and pharmacotherapy of hypertension. That's going to hark back to some of the things we talked about with salt transport and flow. And you're going to talk about bioimpedance plethysmography.
Yep.
The hardest part about that is saying it.
Yes, exactly.
And then I'm going to try to present a unifying hypothesis.
Love it.
And it's not a shocker that involves channels.
Yes, not a shocker.
Not a shocker. So here's Homer Smith again, our favorite guy, he was alive. He overlapped a little bit with FDR. And here just to remind you that the kidney handles water and salt in different ways. We've talked a lot about the way the kidney handles water, promptly excreting it to protect tonicity of the body. And we also talked about the fact that saline is handled much differently. It's not a quick feedback system.
Right.
And there's reasons for that. And there's hormonal reasons for that. And there's a lot of reasons for that. It's not clamped at any one value, but it can get into a steady state. But this is of course that's got to do, water doesn't control blood pressure.
Right.
But saline does, salt does.
Volume.
So let's go back a few years. I say ancient China. I'm going back even before that, to 600 million years ago. So the Cambrian explosion was when all of a sudden life started to just rapidly multiply with different species. So 600 million years ago, here was going on. The Grand Canyon was actually a very tall mountain range. It was peaking. And then our common marine ancestor, which was a symmetrical little thingy that was leaving, according to Homer Smith, leaving the sea and going into fresh water. Homer Smith wrote, and here's a quote, "This ancestor, the likes of which has never been seen, was a frail bodied, ghostly form, possessing bilateral symmetry." I mean, that's beautiful. Mm-hmm. So this is as a Cubs fan,
right?
This is the underdog of underdogs.
Oh yeah, okay? Exactly.
Frail bodied, ghostly form. And this organism just needs to eat and excrete, and no need for a brain. Keep your mouth open, keep swimming, and let the kidney worry about it. Because there was a tubule in each segment. And this ancestor would go on to spawn us. And over those years, from then to now, the Grand Canyon has gone from the high mountain peaks to a pretty deep valley. It's been a long time. Nobody, how long have you been since you've been to the Grand Canyon? Oh, when I was there were mountains.
Right, exactly.
That's a long time ago. So here, one of my favorite slides from Homer Smith. This is from his Evolution of the Kidney book, which I think says it all. He was talking about the evolution of the kidney in 1943. And I have to laugh. He says any resemblance, here was his vision of it, and any resemblance to Amphioxus is just coincidental. Because you know how many Amphioxus people are out there being angry. Yeah. So you see here, this little thing has a big mouth, tiny little brain,
right?
All these segments with urinary openings, which would become the kidney, and would just swim. I don't know that there's a heart here.
It doesn't need that circulation. It's just flowing through.
Right. And its body movements is enough the whole body is a heart.
Amazing.
So between diffusion and the convection occurring when the organism would swim was giving it no need for a closed circulation with the heart. So there weren't many blood pressure clinics going on at this time. This is 1943.
But the urologist was so busy there.
Very busy, very busy. Okay. Now at this point, as we talked about before, when you went from high salt of the sea, 3% saline, the Dead Sea is 30% saline, by the way. And that's why you float so easily on it. But you got to get rid of this. You got to get rid of ways of water to get in. So there was a waterproof covering. The holes had to be brought in, and there had to be a circulation. All of a sudden, the kidney was born, because now the kidney, as we know it, was born. Instead of just a tubule, the water had to be pumped out. This, according to Homer. Some people don't subscribe. I do. But the kidney tubules we've talked about agrees to accommodate the glomerulus, which is a blood vessel.
Right. It's
the best blood vessel. There's no greater capillary in the body than the glomerular capillary, with two arterioles on either side that we talked about. But
part of the vascular system.
Right. But again, when you do a kidney biopsy, you see the gloms, and everybody's saying, well, it's part of the kidney. It's part of the circulatory system.
Right. Exactly.
It's got blood vessels on it, and it's not epithelial. It's got epithelia on it in terms of the podocytes. Anyway, the prenuptial agreement was that the high-pressure arterial system needed to, now, again, this is why you need the high-pressure system, maybe. All of a sudden, you needed high pressure. Nature didn't want that, but now you had to strike a compromise. So there's a high pressure system now evolved. The kidney agrees to accommodate the glomerulus, and the glomerulus was evolved independently of and long after the tubule, which is epithelial. This is when blood pressure was invented, and it was the beginning of the end, because blood pressure was great until it became, when there was no salt around, and you needed to conserve salt. Blood pressure was great, and the kidney reabsorbing sodium was great. But then now that we have salt everywhere,
right?
It's I don't know how much hypertension there was in the 1500s. Okay, nobody does. Now, the marriage is that trusting the cardiovascular system, as every nephrologist knows. I mean, it's funny, most nephrologists don't ever, if they've had trouble deciding what they're going to do their fellowship in medicine resident, I've never run into anybody that said I've run into people that said it's between nephrology and endocrine, or nephrology and rheumatology. And I've run into people that say it's between cardiology and GI. I've never heard anybody say it's between cardiology and nephrology.
Right.
Because
Yes.
they just are different. Just different.
Yes. No, agreed.
Have you? Do you know anybody who struggled between cardiology and nephrology?
I've seen people super interested in both. So I've seen people trained actually.
Yeah.
And so I've seen that like in the city at a few conferences, like a cardio-renal conference. There was a nephrologist who was well trained in cardiology as well.
Right. But what was the initial pathway?
Yes, no, that's
There's
true.
no combined cardiology. In fact, I just saw recently that, now that we have onconephrology, I mean, there's fellowships now in not only nephrology, but critical care nephrology and cancer nephrology. And I heard, I may be wrong about this, I thought I saw it on Twitter, cardio-renal fellowship. Cardio-renal fellowship.
I think that's interesting.
It is interesting.
But the one thing, just getting back to that really quickly, that I think is important is people think of cardiology as a very, procedural specialty.
Yeah.
Like GI and people who like procedures and measuring and, those types of things, as opposed to nephrology, where we're not really procedurally oriented. We basically, except for dialysis.
I saw a recent statistic that I think it was 10 years ago, nephrology folks were doing more than 80% of the kidney biopsies, or maybe 90%. And that the recent data shows less than 10%.
Right. It's all
interventional.
Exactly. Yep.
So trusting cardiovascular system proves to be kind of a disaster, because now everything's being dumped, and you ought to not throw out the baby with the bathwater. And so as we talked about before, the proximal tubule had developed all these mechanisms to save this stuff, including your favorite stuff. So the kidney had to figure out a way not to throw the baby out with the bathwater. So Homer wrote, again, in his lectures on the kidney in 1943, and I think it's worth quoting him because he is, I think, the master. At one end, the heart is working hard to pump a large quantity of water out of the body. At the other end, the tubules are working equally hard to defeat the heart. He didn't do a cardiac no. To defeat the heart by keeping 99% of this fluid from escaping. Thus, heart and kidney are literally pitched in a constant battle against each other, and our lives depend on neither one of them actually winning out. And this is what compels people, because this is just true. Like Star Wars.
That's beautifully written.
It's evil versus good, and somehow good. It's a David and Goliath. Somehow David wins. Star Wars, evil versus good. Somehow good wins. And the bad father turns out to kind of repent a little bit. And then Harry Potter, the name that will not be spoken, didn't win.
Right.
I think a guy named Harry Potter won. Okay. So these compel people, and you can write a book or two on it.
That's what I heard.
In movies. So nature frequently opposes two forces against each other in order to maintain a steady state. And I think you recently said something to me that reminded me of that. You had gone back to look at the Nobel Prize talks this year.
Yes,
you went back to look at David Julius talking about trip channels, and Artem Patapodian.
I was just thinking of that with the trip V1 versus the trip 8 and how they sit there, one measuring cold and one measuring hot, and
figure out where to be in between.
Exactly.
So isn't that the same as nature frequently opposes two forces? There's the cold receptor and the hot receptor.
Exactly.
And that's how you get your warm water.
So interesting. Yeah.
So it's a cold and warm faucet, and you adjust.
Love it.
Okay. Now pits. Now I'll tell you why pits is important. Pits ain't the pits. Pits is great. Pits is important to me for three reasons. Other than the fact that he was a genius and great. When I was I started college in 1975. So I started med school in 1980 or something like that. And in physiology during my sophomore year, I got my hands on the pits for the first time. And because it was 1976 or 77, and the third edition of the Pitts Physiology of the Kidney and Body Fluids was out. The reason also that Pitts becomes important is because Pitts was also the mentor of both, to some extent, Gerhard Giebisch, and my research mentor, Emil Bullpop. And Emil used to say to me all the time, Emil was very involved in the physiology course at Yale, and of course wrote, along with Walter Borum, his student. Both of them became chairs of the Department of Cellular and Molecular Physiology at Yale. And again, I don't think I'm spilling any secret to tell you that the Borum and Bullpop medical physiology book is become probably the physiology book used at most medical schools. Wow. It's a great book. And, you know, they both can trace their lineage to Pitts as well. And here's just one page out of Pitts. And it shows regulation of volume and osmolar concentration of the extracellular fluid. And he talks about volume regulation. You really can't see much in Pitts about blood pressure regulation. Right. You know, even though it was the 70s. It was really talking about extracellular volume being the regulator. Something could sense that. So let's just see. We'll see. It'll come back, but you'll see why I'm presenting that. But the Pitts, and I still love this book, and I still read it. So let's look at the historical highlights of blood pressure. We've already gone over before the heart and open circulation. That was, the old days. And then there was the heart and closed circulation. And then ancient China was probably the first place where they could feel what was called the hard pulse. But it wasn't until 1733, 300 years ago, that Stephen Hales made the first measurement of blood pressure in a horse. Not the first blood pressure measurement ever, and it was in a horse. Then in the late 19th century, Akbar Muhammad distinguishes something that...
I gather he didn't use a thigh cuff on that.
He didn't use a thigh cuff. Okay. I'll show you how he did it.
Oh, yeah.
And then Akbar Muhammad distinguishes essential hypertension as a very important person. And this was before there were sphygmomanometers, because they weren't invented until the 1880s. And then the person who gets a lot of the credit, maybe not deserving all of it, but certainly some of it, is that Sir Thomas Clifford Albert described hyperpiesis, and I like that because it's piezo in there.
Right.
Hyperpiesis as high blood pressure without a reason to, why do you have this? And that's the first clue to, I can measure this, but I don't know why you have it.
Right.
Now, that to me is a clue of maybe they're not as connected as we think, okay? And he gets credit for coining the term essential hypertension. And then right after the turn of the 20th century, in 1905, Nikolai Korotkov combined the sphig and the stethoscope invented by Laennec and discovered the Korotkov sounds, which are the lub-dub that we all grew up with. And for a long time, it was lub-dub. It still is lub-dub. Mm-hmm. Okay, even if it's on an echo, it's lub-dub.
Right.
And those are amplified stethoscopes. But here's where we were as of the early 20th century. Now, Sir William Ulcer was very big shot at Hopkins. And basically what Ulcer said about medicine, he was a great teacher, a brilliant person. But he was the gospel. Basically when there was any kind of a dispute, Ulcer was the arbiter of that dispute. So he had a famous textbook. I have this textbook. I have the 1916 edition of the textbook. I'll show you something from it. But he played down the concern, saying that you don't fool with this thing. The blood pressure is going up.
It's essential. It's necessary.
It's necessary. And then it wasn't helped by the fact that other influential docs like J.H. Hay said treating high blood pressure is a mistake. Okay? And then in 1937, Paul Dudley White says hypertension may be an important compensatory mechanism which should not be tampered with. Now, other than the bad grammar here, hypertension may be an important compensatory mechanism which should not be tampered. Up with which we should not put. So anyway, now things changed in a big hurry after the FDR incident. We'll call that the FDR incident.
Right.
So as of the late 30s, this is why FDR's physician wasn't treating him.
Right. There was no God. There was no
Don't
plan.
tamper with it.
Right.
It
was necessary.
Right. And shortly thereafter, President Truman in 1948 signed the pivotal National Heart Act, which tipped off the Framingham Heart Study. That's still, I think, going on. Mm-hmm. And so all of a sudden, remember, it was hypertension was in 1947 was number 6. This is what put it there. Then it became number 1. And then 1966, Arthur Guyton, very famous physiologist at Jackson, Mississippi, who basically, by the way, he wanted to be a surgeon, Guyton, and he contracted polio and was, paralyzed from polio. And I think that dashed the hopes of a surgical career. But for our benefit, he became one of the greatest physiologists ever.
Amazing. And
he showed, and I'll show you, we'll go into this in detail, he showed that kidney controls blood pressure in the long term. And it was 1967, around the same time, that the first VA study of hypertension was performed. Okay?
I was born. You
were born. So in 1976, there was the first oscillometric blood pressure cuff beyond the SFIG. The Mr. Fit multiple risk factor intervention trial, famous, 1982. The SHEP trial in 1991 showed the benefit for treating systolic hypertension. It was, the top number was important. Then in 2002, when you were in the lab, ALLHAT famous study showed that there was no difference between chlorthalidone, amlodipine, and lisinopril. In other words, a thiazide diuretic was just as good, and not calcium channel blockers and ACE inhibitors weren't better.
Right.
And then a couple of years ago, 6 years now, the landmark SPRINT trial, and we'll go over this a little bit more detail, shows 27% improved all-cause mortality and a 25% improvement in primary cardiovascular outcomes in non-diabetics when you intensively lowered blood pressure below 120, the systolic. And then 2021, we'll look at the KDIGO guidelines. Long document, we'll review the essential part of it, the essential part of the essential hypertension. Yeah. So this is a slide that you don't really have to look at, except for there's time here. And what it shows is the blue lines are the systolic blood pressure recommendations. So in JNC1, there was only a diastolic. This is when diastolic was big. So look at this, Craig. Blood pressure is 2 numbers.
Right.
Okay? And we've been measuring it for a while. And we still don't know. And we're arguing about what those 2 numbers. Okay? And look how long it's taken. First, the focus is on diastolic. Then by the time JNC3 rolls around, the focus is on systolic. And then the focus since then has just been going lower and lower. So these are all the studies here, is ALLHAT, here's SPRINT. They're all here. The bottom line is, the takeaway is, they didn't know which one to focus on. It changed, and then basically the theme has been go down.
Right, for both.
For both. So primary hypertension was considered essential, as we've talked about, and it was essential to force blood through sclerotic arteries. Well, why do you think the arteries became sclerotic? From the barotrauma. So high blood pressure, the other reason I was never a big fan of thinking that blood pressure was the end-all is because it's a positive feedback.
It's a positive feedback system, right.
High blood pressure begets more high blood pressure.
Right.
Which kills the blood vessels. So
never a good feedback system.
Right. You're going to put control in the thing that's killing its own system? It just never made sense to me as an engineer.
Right.
But everybody loved these 2 numbers. And remember, for a long time, we had no idea what those 2 numbers were. Then we did know what the 2 numbers were. And we knew they shouldn't be gigantically high. But is the holy grail knowing the 2 numbers? Or could it be more about flow?
And that's the question at any time. And it reminds me of like PTH and parathyroid. Are we measuring the right thing? Every time the guidelines keep changing or they change these numbers, it usually means you're not measuring the right thing necessarily.
And then FGF23 came out.
Right.
And all of a sudden, maybe it's the boss.
Right.
And I mean, when we do divalent, calcium phosphate, if we do the talk on that, the name of that talk could be "Who's the Boss?"
Right, who's the boss? Exactly.
I mean, that's who's the boss, because PT is vitamin D's in there. Right. PTH used to be the boss for sure, and now FGF23, Clotho is the boss. So
but I think these are the challenging questions: are what are we measuring, and are we measuring the right thing?
So for anybody who grew up, and went through training when I did, there was no FGF23. PTH was the thing.
Right. Right. And
we're looking at it. And a lot of people argue that all that looking at it hasn't impacted much.
Right.
Phosphorus is important, and maybe FGF23 is the thing.
Right.
But we didn't know because that was still in the black box.
So like in this section, is it flow or is it the pressure?
Right. So Paul Dudley White has a famous 1931 textbook. This is the thing. The treatment of hypertension itself is a difficult and almost hopeless task. Hopeless in the present state of our knowledge. And in fact, For all we know, the hypertension may be an important compensatory mechanism which should not be tampered with, even were it certain that we could control it. Was he right? Right. So although no autopsy was performed on FDR, the embalmers noted his arteries were so severely clogged with plaques that the pumping in the formaldehyde,
right.
stopped.
That's when you know you got high impedance.
Right. Okay, so one favorite person of mine is Sir George Pickering, obviously pretty famous because he's Sir. He was not in the Beatles, but he lived in this important era of, he was born the year before Korotkov sounds, and died the year that hypertension was #1 in publications. And he wrote a book, look what he called it, High Blood Pressure.
Amazing.
Okay, by Pickering, Sir George.
To treat or not to treat?
And this is, I gave you this, this is a birthday present.
I don't remember. I do. I think I remember that.
That's a birthday present. So I gave it to you in September 1968. When you were almost 1.
I was almost 1.
Right. So, he sort of said, it seems quite extraordinary. I have to emphasize the basic platitude that arterial pressure is a quantity and should be treated as a quantity, not a disease. And so the current practice of treating it as a quality, good or bad, is responsible for a whole series of artifacts which only confuse. Raised arterial pressure seems to have in man a series of consequences that are related quantitatively to the degree of elevated blood pressure, arterial pressure. But, they were still, all they had was certain tools. They didn't have the genes yet. So here's a paper by him in the British Medical Journal in mid-60s, and just showed that as you get older, systolic and diastolic go up, and even though they may be relatively lower in by the gender, by the sexes, it's basically the pattern. So there's no agreement over the past 30 years. Now, when he was saying over the past 30 years, he's meaning since
30s to the 60s.
Since 1935. Yeah. There is no agreement as to what the dividing line between normal tension and hypertension. He called so-called hypertension. It wasn't even so-called hypertension. And that's what I do. I call it so-called hypertension. Although the WHO, and here he is a political guy, the WHO, that great propagator of science by committee, has made a recommendation. So he thought it was artificial as a continuum, pressure being a continuum. He thought it was rather artificial to draw a line. Okay? And then he says in various complications like MI and stroke, they're clearly, he knew they were related to blood pressure, but he really thought that there could be distortions in looking at it like this. It's a cumulative cycle. So a positive feedback cycle. So of course, Sir George was asked to give a dinner speech on mild hypertension, to treat or not to treat. That is
Were you at this dinner?
Well, this dinner, I was still in Chicago. I was still actually in Champaign-Urbana, and this was in New York. Very disappointed he couldn't be there.
Right.
But he goes off, with apologies to the bard. To treat or not to treat, that's the question. And then he goes on. Wait,
hey,
are we
Alan,
getting a call?
I think we got a call from Sir George Pickering. He wanted to apologize for not inviting you to dinner.
Oh, well,
he felt bad.
Yeah, well, I understand, Sir George, and I don't mind, because I have the book that you wrote, and I have this dinner speech, which gives us some good laughs. So thanks for calling in, and back to what you were doing.
That was our first caller.
Yeah, that was our first caller. So he's asking questions. Might his therapy adjust, and what would the side effects of therapy be? Would there be depression? Because a lot of the early antihypertensives caused depression, not the kind of FDR's depression, but the real depression of, reserpine was a depressive drug, and people felt terrible on blockers of the sympathetic nervous system, guanidine. And I learned about those in med school. I read Goodman and Gilman from cover to cover, and spent a lot of time on those things. But is the dread disability or death? What are the consequences? And so, again, he was couching it as the benefit risks. The great Sir George, Lord, in thy remarks be all that remembered. This was a dinner in his honor, and William McFay Smith gave this poem in the honor of Sir George. Okay, so just to touch on the categories, the artificial as they might be, looking at the categories now, I think, normal, to be considered, quote, normotensive, a person, and this probably should be corrected for age, but it isn't yet, systolic less than 120 and a diastolic less than 80, which would give a mean blood pressure less than 93. And then here's the other, yellow, and this is, and then here's where would FDR is not on the slide.
No, he's not.
FDR is double this. He's already doubled that. The poor guy.
Mm.
Now here, Craig, is an interesting slide that shows how the world is doing with controlling blood pressure. So it's what's the prevalence in a country, how many percent are aware of those people, how many are being treated, and of those people, how many under control. And you could see there's countries that are doing not so well. Ireland is not doing so well, especially among men. Look, Ireland's only is at 17% of men under control in terms of blood pressure. And there are some countries like Canada who are doing pretty well. 50% of the women, 69% of the men. And then here's the United States. 54% of the men, a little better than Canada. For the women, a little better for the women, but significantly worse for the men.
Right.
So,
all of them are bad.
Right. All of them are pretty bad.
The problem, and that's the thing, is there's so many people who are not controlled, and that's a big.
And look at the prevalence in the United States. The prevalence is approaching 50%.
Right.
Okay. I gave a talk a few years ago. I said 1 out of 3. In fact, my slide coming up probably says 1 out of 3, but maybe 1 out of 2. And this is recent data from 2019. And you're right. It's not very good. And since Canada and the United States are pretty much the same geographic location of the world, with Canada just being obviously north, what would explain? I'm interested to know what explains the 20% difference in men. Maybe it's diet. Maybe it's going to the doctor. Maybe it's the
socialized medicine.
So I would like to know this 20%. What are the big factors?
Right.
I don't know, but I'd like to know. Okay, so CJSON just came out. What does it say there as the date? January 5th, 2022.
Yep, December, the date submitted?
No, the date here.
Oh, yeah, January 5th, 2022. Yep.
Is that recent?
Yeah, that's pretty recent.
Yeah, so we're the 19th right now.
Yep.
So that's just over 2 weeks ago.
Yep.
And basically, I plopped out of this it's blood pressure management in the patient with CKD. Because CKD is a major risk factor for high blood pressure. And you see one figure is completely devoted to what, Craig?
This is how to take a blood pressure.
And so you're a country doctor with fancy stuff. What is your, do you rely on home measurements? Do you rely on well-done office measurements? Do you rely on ambulatory blood pressure? What's your method?
Yeah, I think that's a great question. I think in the office, you got to do a blood pressure measurement. That's part of the evaluation, but that's not how I focus on treating people.
So when the patient comes to your office, and they've driven through a blizzard,
right?
Their kids are screaming in the back.
They're anxious about COVID exposure.
They're anxious about COVID exposure. They parked a mile away, and then they climbed 5 flights of stairs to get to your office.
That's right.
And then you kept them waiting.
I never make them wait.
I know, not you. Is that the best time to measure blood pressure?
It's almost as good as measuring a blood pressure right before you jab a 16-gauge needle or a 15-gauge needle into someone's arm.
It's almost like it's the worst time.
It is the worst time.
Okay.
The only time worse is on dialysis.
Yeah, that's when we do it.
No, exactly. So in our office, I actually have 3 24-hour blood pressure machines.
APBMs.
APBMs for 24-hour measurements or longer.
Okay.
And we do quite a few. They're amazing. And they're constantly out. They have their own schedule, and they're constantly out.
From the lending library.
Well, they
check them out.
They check them out. I have loaners. I have 10 Omron 10s that I loan out that people sign out. And then we have an RPM program, which is newer.
Now, how do you think, in just your anecdotal experience, how would you, thinking of certain patients as individuals themselves, their office measurements versus their Omron measurements with the home cuff you gave them, versus APBM? You have any case studies?
Well, I first of all, when I loan the Omron 10s out, they come back with their little thing, and I get daytime readings. So the one thing that's missing is nighttime blood pressure
to see if they're a dipper.
To see if they're a dipper.
Because it's
normal.
What
happens early in the morning.
Can you explain what dipping is for a second?
So there should be a nocturnal dip.
Dipping is not when you take a vanilla cone I thought for a long
Into
time.
sprinkles?
Yeah, when they first started teaching me about dippers and non-dippers, I said, okay, so wait a second. So if you take your vanilla cone, soft serve, and you dip it in the chocolate, you're a dipper.
You're a dipper.
And if you say, just give me the ice cream, you're a non-dipper.
That's
But
right.
it turns out I was wrong about that.
No, you were.
Yeah.
Because
What
dipping.
is it? What is it?
Well, dipping is the natural or
Circadian?
diurnal sort of blood pressure changes over the course of 24 hours.
Yeah.
During the day, our blood pressure is at a certain rate, and at night when we go to bed, it should drop 10 points over the course of the night.
And do people who don't dip, are they in?
They have a higher risk. So people who are non-dippers have a
higher
higher cardiovascular risk.
Okay, so dipping is a good
So
thing.
it's important. And it's good.
And you picked that up with APBM.
You picked that up with a 24-hour blood pressure.
Okay, so can you think just off the top of your head? I'm putting you on the spot. Can you
I
think
don't
of
know.
can
I
you
love
think
it.
of a particular patient where you can remember their office measurements, you can remember their daytime measurements with their own Omron at home, and then you got their APBM data and gave you insight?
The 24-hour blood pressure always gives me insight.
Okay.
And I can
Do you
show
see
it to the
dippers and
patient.
non-dippers?
Absolutely.
Okay.
And actually, the machine that I particularly use, which I love, is gives a great analysis and has good software that goes with it. I'm not pumping up anything, but I'll
No.
put a link in the bottom.
But how do you? Let's say you see somebody's not a dipper on the APBM. What is your plan to turn them into a dipper?
Well, I mean, that's the point, is that if you taking blood pressure medications at night makes a difference.
No wonder I take mine at night.
Exactly.
Oh.
And so I think there's good evidence that that's part of it. And in our business, which is nephrology and tough to treat hypertension usually,
Yeah.
these people have to take twice-a-day meds. And I always make sure some of their meds are at night before they go to bed.
Exactly. So
And that's
I
the
mean,
protective effect.
Since I went on blood pressure medicine, which is now at least 12 years,
Mm-hmm.
I don't know if I was a non-dipper, but I've taken my blood pressure medicines at night before bed to try to give myself back the dip. I don't have measurements now to know if I'm dipping now, but I have a better chance of thinking I'd be a dipper by taking the medicine at night than at day. Now, people say, oh, but I don't want to take my medicine at night because, well, Dr. Seeger, you take your chlorothalidone at night. Doesn't that make you get up and pee? No, because the thing that determines how much pee I'm going to make is how much water I've consumed throughout the day. And I have, sort of gotten into the habit of knowing that I'm going to get up to pee if I have water. The chlorothalidone, especially in the steady state, doesn't make me pee at night.
That's amazing. Right.
Right. I mean, you remember, I remember the, on the way to work in Chicago, I passed this bench where there was 3 older Jewish guys complaining to each other. And the first one says, life ain't what it used to be. When I was a young man, I would get up and I would pee like a racehorse. A great stream, great stream. Life ain't what it used to be. And the second guy goes, that's nothing. When I was a young man, every morning, a beautiful constitutional, beautiful bowel movement. Now I'm sitting there reading the New York Times Magazine. Nothing. Life ain't what it used to be. Third guy says, that's nothing. Every morning, 6 a.m., beautiful urine stream. Every morning, 6:30, beautiful bowel movement. What are you complaining about? I don't get up till 7.
Right, exactly.
So that's a classic joke.
Before we get off the measurement, one other new tool that we have for measuring blood pressure in elderly people that's very useful is remote patient monitoring. I don't know if you were using that much. But
Telemetry?
Nope. Remote patient monitoring is
Because
Medicare.
I just want to interrupt for a second and say that when you have animals in the lab,
Mm-hmm.
when you're doing, let's say you're using, and we're going to talk about doll rats. If you have mice or rats where you're measuring their blood pressure and you want 24-hour readings,
Right.
they're outfitted with telemetry.
Right. So
That's remote, but telemetry. This is something different. Go
this
ahead.
particular thing is a Medicare covered blood pressure tracking system for elderly people. When you have young people who are real savvy, it's great. You get their home readings.
Mm-hmm.
But as people get older, especially our older patients like late 70s, 80s, early 90s, we want to know what their readings are at home. They're not writing stuff down. They just want to put their arm in a cuff and hit a button. These machines get shipped to them with a cell phone chip that sends the readings right to my office. And so these elderly patients who only know how to use a cuff, literally I got all their readings as soon as they walk in.
Well, now that I'm 87,
it's going to be great for you.
Yeah, I qualify.
You qualify.
Yeah, because I watch a commercial that says check your zip code, see if you qualify now. So again, if you look at this slide and you see the patient seated, seated comfortably,
Right.
feet on the floor,
Yep.
rules about talking.
No crossing your legs.
No
relaxed.
crossing your legs. You got to tell people at home,
Right.
you got to sit right.
You got to sit.
Cuff at the
correctly.
right level.
Yep.
Not everybody puts the cuff on right. I've seen even
Right.
doctors not put the cuff on right.
I know.
Yeah.
That's true.
So that Velcro's confusing. So do you kind of follow this?
Yes.
Talking? What's the talking rule in your office?
Yeah, we actually. Oh yeah, no, we have no talking during blood pressure. The patient.
How about during
sits there.
podcasts? Talking aloud?
You're allowed to talk during the podcast. No blood pressure measurements.
Right. So you'll
during
notice
podcasting. There's no machines here.
We have not taken a blood pressure as in the history of our podcasting.
We've never done a blood pressure
Never.
while
And
podcasting.
why? Because we're talking.
That's right. Exactly.
So you have rules. So would you say that your office pretty much does the very cutting edge see Jason January 5th paper?
We do, and we have a handout that we give people when they borrow the blood pressure machine on how to do an appropriate home reading.
Okay.
Honestly, office pressures are not great. We know that from many studies. Either you're sending people home or they have their own cuff that you validated, or you do a 24-hour blood pressure.
And this is a
test
big
on them.
problem because
It is.
a lot of the studies, first of all, the studies that are older, there were no home blood pressures. People
Right.
didn't have meters. So by necessity, older studies are based on office measurements when there could be white coat hypertension.
Right.
What's white coat hypertension?
When you come in and you see someone with the white coats.
So white coat hypertension means that you're normally not.
Your blood pressure's normal, but
Pretty-
when you come
pretty
to
normal.
the office,
Yeah.
you get anxious.
Well, wait a minute, but what's masked hypertension then?
Masked hypertension.
Uh-huh.
Go ahead.
No, I'm masked hypertension. Maybe you are hypertensive, but when you come to the office, you look good, and so that your hypertension is masked to the clinician. The clinician is blinded to your high blood pressure. When I developed my high blood pressure, I said, "Well, I'm a doctor. I got white coat hypertension because I can see my white coat on the couch there."
Always.
So the first thing I did for my blood pressure was put myself in a place where I couldn't see my white coat.
Right. And it's the other.
Then I worried about the white coat, and
it goes right up.
then
And
I thought I
some
had
people
masked
even
hypertension.
have that with their blood pressure machine. Literally, they get anxious walking up to their machine.
Right. So what you're saying is that white coat hypertension is called white coat hypertension colloquially, but that what it really is my blood
Hypertension.
My blood pressure went up because I'm afraid I'm about to measure my blood pressure.
Exactly.
Yeah. So that's white coat hypertension. But one of the big things I think that shows up on medical boards all the time is one of the big uses of APBM, especially the way you've talked about it, is to make sure who's got white coat hypertension. We don't want to be over-treating people who are only hypertensive when they come to the office or whatnot. And who's got masked hypertension? It's really out there at risk,
Right.
but they look good to us.
What's funny is I do occasionally get a patient who gets referred with syncopal episodes and they're overtreated. I put them on the 24-hour blood pressure machine. They come in, the blood pressure's high in the office.
Right.
Put them on the machine. They're hitting 70s in the middle of the night.
Right. Well, when I was a fellow at Yale, as I told you before, I used to always go down to Broadway every weekend, and I saw Phantom of the Opera, 20 times. And I also bought from the Schubert Alley gift shop there a Phantom mask. And whatever social life I had in New Haven those days, I would go out on a date and have the Phantom mask on. And my date would be pretty happy. And the one day they said, be good to see you without the mask. I go, all right. And that was the end of the relationship. So that was kind of my mask better social life.
Right, I see.
Yeah. So, so unfortunately, the mask doesn't always work.
No.
And the mask may also mask you from seeing things like they really are.
And I think that the big picture here is getting an accurate blood pressure is the most important part of treating people appropriately.
Right. And when people ask me, what's my blood pressure?
What do you tell them?
I don't know. I've never known. I mean, even a stop clock is right twice a day.
Correct.
But there's an old saying, I think this is one of the corollaries of Murphy's Law, which they tell me is called Siegel's Law, not after me, is that a stopped clock is right twice a day, but a person with two watches never knows what time it is because the two watches are always going to read different times. So I don't know. I mean, my blood pressure is something when I measure it, but I don't know how representative that is of my whole day.
Right.
The 24-hour gets you closer.
Yeah.
And helps people distinguish white coat all the good uses plus white coat plus, so maybe in some of your APBMs, you've picked up some masked hypertension.
Oh yeah, I mean, those 24-hour blood pressures are the most important tool for my hypertension
great. But
management.
not a lot of studies are based on that.
That's for sure.
Right. So we got much better measurements now, but they're discordant and disconnected.
Correct.
From the studies.
Good point.
So the other thing in this figure is that what are the targets? What are the preferred drugs? And as you'll see, it's essentially ARBs and thiazides.
Right.
And chlorthalidone has been shown recently in a New England Journal article to be. I've always loved chlorthalidone in advanced CKD, and a lot of people said, well, thiazides lose their effectiveness below 30 below GFR of 30, but obviously not with chlorthalidone. So and they go over the fact that this ain't perfect. So this is how hard it is to do these studies, because just to get a measurement is a federal case. Now, here's what Sprint and KDIGO 21 has said. They start here. So, this is like, use a combination of, don't just add, it used to be one drug at a time and add on. Now it's not. It's begin with 2 or 3
Combo
drugs.
therapy.
A thiazide, and we're going to talk about why that could help and what that does to the kidney function curve. And something to inhibit RAS.
Right.
And maybe calcium channel blocker. And then they go through an algorithm here of, are you doing this, are you doing that? But the targets are clear. You want to be below 120 systolic, and you want to be below 80, really, for diastolic. So this is everything that we've had up till now led to this. Okay, 2 numbers, Craig.
Yep.
2 numbers. So how big a problem is hypertension? Well, high blood pressure is the major public health burden. About 1 billion people have it. That's probably 1 out of 7, probably more. More pervasive where there's more salt and more stress. And I don't know what. We have all the technology, but the lowest blood pressures in the world are in places where the 24-hour sodium excretion in the urine is less than 10.
Right.
It's the single largest contributor to death and disability. When you get insurance, you don't need insurance because you're young. A guy like me who's decrepit needs all sorts of insurance. I need insurance on my insurance. And when I applied for the insurance, I thought they'll want to know, show them my CV, I look like a good risk. No, here's what they want to know.
Blood pressure and if there's protein in the urine.
And if I smoke.
Right.
So smoking, so those are the things. Protein in the urine, because protein in the urine and high blood pressure, those, GFR and protein in the urine is the prognosis for your CKD.
You got it.
Hypertension is what can decrease your GFR and give you proteinuria as well, and diabetes. So they really want to know the big ticket item. The actuaries are saying, forget some of this stuff. Here's the biggies. And the biggies are what's costing them money. And then a classic study, I don't know if it still holds up, but the classic study was starting at 115/75. For every 20 millimeters you go up in systolic, and every 10 millimeters you go up in diastolic, you double cardiovascular mortality. That's huge. So all those people saying in the 30s, don't treat the blood pressure. Apparently not right.
Right.
So here's stroke, for example. Stroke and ischemic heart disease mortality in age, and you see these are straight lines.
Mm-hmm.
I mean, this is not rocket science right here. This says you're going to die of a stroke, and it's lowest at 120.
Right, but one of the other things this shows us is your biggest bang for your buck is in your younger patients, and as people get into this much higher age group, big drops in their blood pressure have less of an impact. So going from, below 160 is important, but going from 160 to 140 or from down to 120 in an elderly person isn't as big a bang for your buck as in a younger person.
But I want you to consider something.
Because these slopes are different.
But I want you to consider something.
Yeah.
When I had my college physical, I remember my blood pressure was perfect. Okay. And then when I was 50, some 30 years later, I remember my blood pressure was terrible, 165 or 105. Now, at what age between 18 and 50 did I become hypertensive?
Yeah, it's a good question.
I don't know.
Right.
Nobody knows. So I would have been well advised now I'm on losartan and chlorthalidone. I would have been well advised to have figured out when I crossed the threshold of becoming a hypertensive person and nipped it in the bud. Okay, because I don't know, did I become hypertensive at 49? So now I didn't lose much time, or did I become hypertensive at 20?
Right.
That's my burden of hypertension.
Right.
And so the point is that blood pressure masquerades as a vital sign. Now look at all the other vital signs. Take temperature. As you age, should your temperature go up until you're boiling? No. So one of the
Essential
things,
temperature?
One of the things I think about with vital signs is they should be steady state and not change. Your temperature should stay constant through your life.
Maybe what is staying constant is your flow.
Right. So maybe. But the whole point is blood pressure, again, doesn't even fit into the rubric of a vital sign. It is a vital sign. But I mean, a real vital sign is something that you're controlling in the steady state that doesn't change, like temperature. You know, your pulse should stay around 72, your temperature should stay around 37 degrees centigrade, and your respiration should stay around 12 to 14 a minute. Blood pressure is the one that's so back in the day when they were saying let it go up, well, what about all the other blood pressures? Glucose, O2 saturation. Will let that go down with age?
No.
We don't think that's normal.
No.
Right. So you're right about that. So it's the most commonly diagnosed, it's 1 in almost 2 now. The most common reason for a physician visit.
Absolutely.
Okay. 82% are now aware. 75 are receiving treatment. Only 53 have the hyper. And look at the cost. Just in the United States, I think, $73 billion. Now let's look at the history. So in China, around 2600 BC, there was the hard pulse. Then some time passed. And then it was treated with bleeding and leeches. Now, Craig, you're a country doctor. Tell me, I know you got your fancy automated blood pressure cuffs, but you don't use those until somebody's failed the bleeding and leeches, right?
That's correct. I always start with bleeding, 24-hour bleeding and leeches.
Yeah, I got Omron leeches.
Yes, exactly.
Yeah. So leech sartan. So what about our medications? Well, chlorothiazide was our first real blood pressure medication that didn't make people feel miserable. Thiazide, obviously. 1958. So 1958, that's younger than me by a year. So we haven't been treating blood pressure for very long. It's just essentially we've been treating blood pressure for my lifetime, which is essentially just over 60 years.
It's brand new.
Yeah,
the treatment of blood
even
pressure.
Even 87, brand new. So for all those millennia since the heart developed, no treatment. Now here's the fun part. So 1733, this happy-looking fellow, Stephen Hales, published the first recorded measurement of blood pressure. Here's how he did it. So I guess this was his student. Here's Hales. Now do this once, and they're going to teach the others. And what they're doing is they're putting a pipe into the carotid artery of a horse laying down and measuring the laying blood pressure in the carotid artery. So 1733 used a brass tube to cannulate the carotid artery of a horse. And again, nearly 300 years later, we still don't know the two numbers. Yeah. Now, blood pressure wasn't measured in a human until not long before the Civil War. Amazing. Okay? So, really, and they didn't know what to make of it, obviously. And again, it was hard because there weren't SFIGs until the 1880s. So after 300 years, we still don't know the two best numbers because look at, again, this is just, don't read this. This is just a review from the NEFSAP a year ago.
I love the drunk guy looking for his keys.
Yeah. So I mean, that's an old joke is a cop comes by and sees a drunk guy staggering around, looking for his keys, looking for something. And the cop says, "What are you looking for?" He goes, "I lost my keys." And the cop helps him for a while. And then they're not finding it. And the cop says, "Where's the last place you saw them?" And he says, "Over there." He says, "Well, if you saw them last over there, why are we looking over here?" And the answer, the drunk says, "Because the light's better here." Right, so the whole point is,
right,
that wasn't the right. It was the easiest thing to see. The easiest thing to see,
right,
was not the measurement.
But we're not looking in the right place.
Right. Right. So I think so. Here's, of course, our pioneer. He did studies before this VIG was there, and he was the first person to point out that you could ostensibly look otherwise perfectly healthy. Now, maybe you weren't, but you looked perfectly healthy and have high blood pressure. Here's the SFIG in the 1880s, the famous people, and then Korotkov with the sounds, combining the stethoscope with the SFIG. And then here's Sir Thomas. He invented the clinical thermometer, the ophthalmoscope, all these things. I don't think he's getting residuals for that.
Wow, that's awesome.
Yeah, he's pretty good. And he was the first one to formally state and gets credit. People could develop elevated blood pressure in the absence of otherwise looking bad with the heart or the kidney. And he coined the term hyperpiesis as high blood pressure, and he gets the credit. Now, what does Sir William Osler think? This is from my textbook, The Principles and Practice of Medicine, the 11th edition, in 1916.
Love it.
And this is a page right out of the book. Diseases of the circulatory system. The blood pressure varies greatly in different individuals, and the same individuals under very condition. The normal blood pressure is from 120 to 130. Look,
He had the right
numbers.
Actually, he's elevated blood pressure, but he's got it, right.
Yeah. But in persons over 50, it's often from 140. So he's pointing out the
right
age.
on the money.
He's right on the money. He was just wrong with his conclusion.
Yeah, let's see.
Permanent pressure may be called high, but there are great regional differences, variations. Then he says high tension. I love that. High tension is met within many chronic diseases. Love how they spoke. Cardiac and kidney, and lead poisoning. Okay, but there were three groups,
and above all, in connection with general arteriosclerosis.
Right.
So he picks up on that.
He picks up on that. Briefly, there are three groups of cases: simple high tension, what Clifford calls hyperpiesis. In this well-recognized condition, they're otherwise healthy, but their blood pressure is high, above 180. So here's what Osler was saying. But he wasn't talking about treating it. So he said, what are the causes? Well, syphilis, which was, I guess, a biggie out back then, was a cause.
Overeating.
Yeah. And
Bang.
Well, was it overeating or being, you can eat a lot and not be obese. Was it overeating or being obese?
Right.
Then the stress and strain of moderate, that of course, peptic ulcer disease was,
The
you're
number
under
one.
you're
Right.
under too much stress. But, so when people say, they come into your office and their blood pressure is high, they go, yeah, I've been stressed. What do you say when they say, I've been stressed?
Yeah, no, I always tell them it's like the soup. No one really knows what's in there, but it's in there.
Yeah.
I never poo-poo people because it's in their mind.
Yeah, it's a sympathetic outflow. But
Right.
the thing about it is I've seen many people under no stress have terrible blood pressure.
Of course.
And I've seen people under great stress have fine
Normal blood pressure.
So it's not stress itself.
Correct.
It's like you say, it's the soup. It's part of everything else going on. Overwork of the muscle. So this would be saying don't exercise. But here's the key. And he picked up on the fact that there's a big relationship. It's been much discussed. So in 1916, it was already, the relationship between arterial and kidney disease is much discussed. Okay? And there could be this secondary form, not essential. So, they're saying bad things can happen, but also bad things happen unfortunately, this was well before there were thiazides. So in 1937, a raised blood pressure, like a raised body temperature, it's merely a symptom. And that's true. It's just like, fever doesn't tell you, a raised body temperature doesn't tell you, what the infection is. So you needed cultures, stuff like that, and then you need antibiotics.
Right.
So he was just saying the raised blood pressure just tells you
something bad is about to happen.
Something's wrong,
like
and we probably need to find it and get a treatment.
Right.
But our conclusions are thus essentially negative. We are present completely in the. I love this.
That's amazing.
No wonder it wasn't in the New England Journal. We are this is in the post-medical journal. We're completely in the dark about this common and disastrous disease, and this is still before studies were being done on it.
The ground is being slowly cleared.
Slowly. So here again is what Hay and Paul Dudley White said that didn't help. Okay, and I don't have to read those again, but there they are. There's the quotes, and they're quotes.
Right. Great.
So, here's what these doctors were saying beforehand, but after 1945, and this happened to FDR, and they saw it coming. You had all the CIA people and still didn't see this coming.
Right.
Okay. And I think I might have read some of this, but Homer Smith was saying various disorders lead to diastolic, systolic. The upper limits of normal are difficult to define arbitrarily. 90 systolic, 90 diastolic, 140 systolic, and for a long time he wasn't wrong.
Right.
My understanding is, maybe it's changing, but pregnant women are allowed their blood pressures that high. And then what did the psychiatrists think? Read this, Craig, because I can't read it.
All right. The psychiatrist has reported from investigation of a few hypertensive individuals that such persons tend to display exaggerated dependent strivings, submissiveness, coupled with stubbornness, feelings of weakness and defenselessness, suppression of hostility, fear of injury, and emotional detachment that may lead to acute emotional disorders. That essential hypertension may be a somatic manifestation of a psychoneurotic condition based on excessive and inhibited hostile impulses. That protracted resentment may be a specific leitmotif running through the anxiety and insecurity of the emotional pattern.
Okay, now, despite the fact that that's a perfect description of me, okay, I mean, that fits me to a T. I think psychiatry missed the mark here.
Except for the submissiveness, I would say it mostly fits with you.
It missed the mark. And so, although I agree, they know me well. So even in 1925, we knew about the age thing, and we talked about Osler. So what is essential hypertension? These days, we know it's this continuous distribution, and it's based in the kidney. We're going to see, and it's bad for the cardiovascular system. And now the optimal blood pressure, at least now, is defined as less than 120/80. People want to know, well,
what's the number?
I mean, when the students ask me, what should your blood pressure be? I say, you know what I say? And I believe it's right. Have I ever told you?
No, let's hear it.
So a student will say to me, well, yeah, Dr. Siegel, you talked a lot about blood pressure here. So what should your blood pressure be? And I say, high enough to think and pee. Anything above that's going to hurt you.
Good
high
point.
enough to think and pee. And that's all I want. My blood pressure now on my medicines is, runs about 128/75. Not perfect. It was perfect at the time I started. That was the target initially, but still not perfect. But it should just be high enough to think and pee. And
that's basically organ perfusion. You want optimal organ perfusion.
Right. And when I gave up grand rounds on this 20 years ago, somebody said, what is the optimal blood pressure? And I said, 116/75. And they said, why? And I go, because if you take 116 divided by 75, you get 1.619, which is phi, which is magical. Awesome. There's a whole, you know about phi? You know about phi?
No.
Phi is used in architecture.
Okay.
It's called the golden ratio.
Okay. Cool. I
it.
love it.
It's got a lot of. If you look at mollusk shells and the way there's a huge number of things in not only biology, but also architecture.
I love these meaningful things. Like, all right, there's a triangle, but what is a triangle? A triangle is like three sides where all the internal angles add up to 180.
180.
This is like a phi, this magical thing.
Yeah,
this is thinking.
But it's called the golden ratio for. So I came about that by saying, okay, if mortality and stuff goes up above 115, let me start with 116. It's an even number. And let me divide 116 by 1.619.
Right.
And see what I get.
Oh, I love it.
And I got 75. So I said,
so magical.
116/75 is the number because then your ratio is phi.
I think that is key, and that should be the number.
That is the number.
That's it.
It should be the number. So here's again more age stuff and all the risk factors. I'm not going to belabor that. And then the awareness we've talked about. So what are the benefits of treating hypertension? Well, the big benefits of treating hypertension are to not have a stroke. Right. Or heart failure. It's really the cardiovascular one. So when people say, "Oh, you nephrologists want to, you're just trying to protect the kidney," guess what? We're trying to protect you from having a stroke.
Right. I talk to people all the time about organ health. I try to stay away from saying this is good for your kidney. Yeah. And I always say this is good for every organ in your body.
When you ask men, at least a subset of men, how do you want to die? My patients who are often in Vermont.
I can't remember the last patient I asked that to.
No, I didn't ask it to patients.
Okay, I was just checking to make sure.
I'm saying, but patients have volunteered it to me.
Right. Okay. Got it.
And I'll say, look, this can kill you, blood pressure. And the patient says, how? And I said, well, how do you want to die? And one of the most common answers I get is, I want to be on my tractor,
exactly.
doing my thing on my tractor, and have a massive heart attack.
Just go.
And the last thing I want is a stroke.
Right.
that doesn't kill me, but basically makes me so
Incapacitated, and all I can do is sit in my living room and look at my tractor.
Right. So these men would rather have a massive MI
Right.
than have a stroke.
Sure.
And so then I say, well, you ask me why this is dangerous? Because you're going to have a stroke. And that gets them, well, yeah, but if you told me I was just going to have a heart attack and die, I'd be out of here.
Right.
But
if it's going to protect me from a stroke, that's a different story.
That's a different story. So, I mean, we all know the only thing that's worth a stroke is excellent pastrami. Or as I said in Princess Bride, a mutton, lettuce, and tomato sandwich with the mutton is really nice and lean. I love that. The potatoes are so perky. I love that. So, right. So it's really a cardiovascular thing. Now the kidney comes along for the ride because what's good for the heart is good for the kidney, and what's good for the kidney is good for the heart. They get along. So, kids. You look at kids on the playground, and nobody's measuring their blood pressure. But if you did, they're all in a high flow state with low pressure.
Right.
They're living the life of high flow, low pressure. And that's good for the heart and kidney. That's the way nature wants it to be. Now, don't forget, back in the day, back in cave people days, you were doing pretty well if you lived to 40.
Right.
So why do we have 3 coronary arteries? I mean, MI is a big cause of death. Wouldn't it have been better to give the heart more than 3 arteries?
More collateral flow, right.
And the reason is simple. I mean, not simple. My idea is that back in cave days, nobody lived long enough to get coronary artery disease. The big causes of death, starvation.
Getting eaten. Traumatic.
Nothing to eat.
Right.
Or being eaten.
Right, exactly.
Or falling down or getting clubbed over by another. Right. So an infection.
Right.
I think it was before antibiotics.
Right, absolutely. I heard that.
So the big causes of death, let's say the top 5 back in cave days, Flintstones, would be starvation, getting eaten, getting an infection and dying of sepsis, sure. Trauma of some other kind, or some other crazy infection. If you lived to 40, they had a gigantic party for you. Nobody ever said I have.
It was like your 90th.
No cave.
We're having a 40th here. Come over to the cave.
Yeah. No cave person ever said I'm having chest pain. If they were, it was because now people say, well,
it was a bridging vessel.
No, people, the thing we learned in med school, what's angina? Somebody says it feels like an elephant is sitting on my chest. Well, back in those days, that was the main cause of chest pain.
So true.
It wasn't like an elephant because an elephant was sitting on you. So it used to be. So they go in, they see the ER, in the cave ER, in the ER cave.
Exactly.
What's this patient?
It's the urgent cave.
What's this patient here for? Chest pain.
What happened? About an hour ago, he felt the chest pain. He felt like elephant was on his chest for about an hour.
Yeah, elephant was sitting here. So this is exactly the point, Craig. So yeah. So there's some things.
Recovery.
Yeah. So I'm gonna, before we go into the mechanistic details, which we're gonna spend the rest of the time on, here are some emerging clinical tips for controlling blood pressure.
All right.
Now we now know that you lower the dietary sodium to potassium ratio by increasing dietary potassium intake and decreasing dietary sodium intake. And that New England Journal article that we went over showed higher K intakes, and the higher your ratio of K to sodium decreases sodium. K intake acts as a diuretic. K, you eat the oral K, it dephosphorylates the sodium chloride cotransporter in the early distal tubule, and you natriurese. So that's the feed forward that we talked about that time. So you get a natriuresis. And also a higher K gives you a slightly higher plasma K. And although higher plasma K you tend to think it would depolarize, it depolarize the cell and make vascular muscle tighter.
It hyperpolarizes.
It hyperpolarizes because there are inward rectifier K channels, small inward rectifier K channels, that actually open more at a certain, they close eventually, but they open more, and the hyperpolarize before they so the membrane potential, because they open, hyperpolarizes before they depolarize. They actually get vasorelaxation. So that makes a lot of sense to me. Also, higher Ks we've known for I think a long time that makes platelets less sticky. So that's big. You don't want your platelets clotting. So what's new with anti-hypertensive treatment? We always know that exercise is good for you and this kind of stuff. But what about the drugs? Thiazides are still hard to beat. They're superior to other drug classes associated with better blood pressure control. I mean, chlorthalidone lowers blood pressure more than maybe anything. And the thing you have to avoid is hypokalemia. So as a stone former, in addition to all the stuff the psychiatrist said about me, I'm also a stone farmer. So it's embarrassing to be a nephrologist who's got high blood pressure and kidney stones. But my chlorthalidone not only helps my blood pressure, helps my kidney stones. But because kidney stones are more likely when you're hypokalemic because of lower citrate in the urine, and because hypokalemia is not good for you in other ways, I also take K-citrate. Gives me potassium,
citrate,
and citrate.
Beautiful.
So the reason I take K-citrate, so my doctor once said, well, why do you take K-citrate? And I go, I take K-citrate because both K and citrate are good for me. And I found out you could buy K-citrate. Where'd you learn that? It was on our shelf in the lab.
That's it.
Yeah. So it turns out that non-dihydropyridine calcium channel blockers are inferior. And compared with monotherapy, we start with combination therapy. You saw that. It's no longer the days of start you on one drug and see what happens. It's a 2-drug, maybe 3-drug. So I'm really on 2 drugs. I started them both together and then added the K-citrate. And I think I said it here. It's better. It may be better. I believe it's better to take it before bed. In the COVID-19 era, do not stop ACEs and ARBs. I know there's been some early on. There was some misinformation about it. Questions or misinformation, but don't do that. So other tips: never miss obstructive sleep apnea. This is a reversible cause, and I'm sure you've seen patients who, once their sleep apnea was treated, their blood pressure improved.
Definitely.
And why does it happen? Well, the hypotheses are everything from increased sympathetic tone to catecholamines to angiotensin to aldosterone, basically everything. And effective treatment of OSA mitigates the changes. Oh, Craig, important. Work less than 35 hours a week.
That'll work.
Yeah, so when you go to your employer and you say, I can't work a 40-hour week, look what the doctors say. But there are studies on this. Observational data, it's observational. So that working greater than 48 hours, most doctors work at least a 60-hour work week. When I was an intern, I worked 110 hours a week.
Right, exactly.
And they made $1.37 an hour. So it was big money. So observational data suggests that working greater than 48 hours a week is associated with a higher risk of hypertension compared to working less than 35 hours. So I bet you my blood pressure was probably pretty good until I started working 110 hours a week.
Yeah, so there you go. That's probably the age things kicked in.
I was an intern. All right. Lifestyle modifications, obviously. This is not rocket science.
But I think these are super important. And I will tell you, we do a lot of dietary counseling in the office here.
Yeah.
Because I don't eat meat and I eat like a very low sodium diet.
Right. I'm a vegetarian too, except for the beef, the chicken, and the pork.
Yeah, exactly.
I'm vegan.
But I would tell you that with people sodium restricting, a lot of time when I see young people and I do a dietary history on them, which I do all the time, their blood pressure is often related to massive sodium intake.
What do you tell them about alcohol?
I ask them about it, but I don't say too much. I mean, as far as blood pressure goes.
Well, the newest recommendations say that for most people, any amount of alcohol can increase blood pressure. So I remember the time where a couple glasses of wine were supposed to be good for you.
Yeah, like one glass.
Right, and they may be for some people, but the data show, if you look at what the data show that for most people, the only amount of alcohol that's the least risky amount of alcohol is 0.
Right, and with every glass anything you go up, it gets worse. Your mortality goes up.
Right. So I'm a deeply closeted vegan, and that's why I eat all that beef.
But it's a high sodium diet out there, and people who eat out more than a few times a week, or even less than that, they're taking in a lot of salt.
So these are the big tips, and they're not. Again, these are not big surprises, and they're not.
We know this.
I mean, I think that even the high potassium to sodium ratio is not a shocker.
Right.
If you understand physiology and you've looked at the studies on what the effect on platelets and membrane potential, and the fact that what it does to the thiazide sensitive co-transporter, eating a high K diet like being on thiazide
makes sense.
Yeah. So, and also a big thing is, and I've spent a lot of time at the dentist lately, so I'm being very good. Anti-hypertensives have been shown to be less effective in the presence of gum disease. So it's not just, periodontist,
But these inflammatory triggers affect our endothelial function and affect blood pressure.
I mean, things like C-reactive protein that shows your inflammatory state. And again, if you have CKD, or worse yet, ESKD, you really are in an inflammatory state.
Oh, yeah.
You don't want to do anything else. Keep those gums healthy. All right. Now we get to our favorite part of the discussion, because we've talked about a lot of stuff we've talked about the two numbers, but we haven't said a word about what's really causing this.
Yeah.
Okay. So we get to the point now where the hypothesis we're going to look at is the hypothesis that blood pressure is controlled by the kidney. Controlled by the kidney. Now, a lot of people, big fans of the baroreceptors and the sympathetic nervous system and the heart, they want those things to control blood pressure. And to some extent they do, but not in the long term, not in a steady state. And
Who's the boss?
Who's the boss? And the kidney is the boss. And again, if this hypothesis is correct, then the cornerstone of treatment would be thiazides. And guess what? It's a cornerstone of treatment. One of the cornerstones. So it wasn't until the 60s that this became a topic of intense investigation. And let me just show you something. So here's a New England Journal Review article from 8 years ago or say. And what this says is that, you eat a high sodium chloride diet, it's bad for blood pressure, it's bad for the heart, it's bad for the blood vessels, it's bad for the kidney, and all these things are connected. Okay? And so, you got to lower your salt intake. It's not, you're never going to do worse by lowering your salt intake.
Look at the salt intake on those, in those groups. It's almost 3,500 milligrams per day.
So 3.5 grams. So remember, to make a liter of saline is 9 grams.
Right.
That's a liter of saline, is 9 grams of NaCl. And, we want people to eat less than 2 grams of sodium, which means less than 5 grams of NaCl.
Right.
That's what you want to do. But, the kidney is so good at reclaiming sodium, you don't have to worry.
Yeah.
So here's something interesting that supports it. So I like the Doll rats. The Doll rats are very famous.
Pass the salt.
So in the 60s, Lewis K. Dahl, who had been a Canadian, born in Canada, I think, and had grown up, kind of in the wilderness, went to some good schools, including Harvard, and became interested in high blood pressure. And so interested, in fact, in the diet of high blood pressure. So he developed strains of rats, one of which was genetically predisposed to develop salt-sensitive hypertension. And the one that was salt-sensitive was called the Doll S rat. And the one that was resistant meant that on a low-salt diet, they both had pretty good blood pressures. This one was still higher. On the high-salt diet, this guy
shot up,
and this guy seemed okay. Well, they did some studies, I think it was published in the mid-70s, 72 or 74, where they did transplants. They swapped the kidneys. And when they swapped the kidney, the hypertension went with the kidney.
Amazing.
So this is animal data. This is whole animal data. The only difference between these two cousins or brothers is what's your kidney got. And whatever it's affecting transport, however it's affecting something in the kidney. And I don't know what it is. I mean, to some extent, sodium transport, you would hypothesize, but it could be more complicated. But just say, here's a whole kidney. You are salt sensitive if you have a salt sensitive kidney, whether you were born with it or whether we transplant it. And if you were salt sensitive born that way, we give you your cousin's kidney, you're resistant. So this is really powerful.
No, that's major.
Okay. So this makes me say that we have to talk a little bit about homeostasis, steady state, and feedback. Because again, we want to be grounded in fundamentals. Homeostasis we've talked about is refer to the ability of a living system to regulate its internal environment in a steady state. What's a steady state? Steady state is overall homeostasis that involves the maintenance of multiple steady states, usually achieved by feedback control systems. So what are feedback control systems? They're systems designed to obtain a desired output or a response by combining an input with a feedback signal.
Right. We've built a few of those.
We did build a few of those. So one example is you control your finger to point to and follow a moving object. You're basically looking at the error signal, the difference between where the object is where you are pointing and where you want to be pointing, and you move. What's doing that? Well, you have a vision, takes the input, sends it to your brain. Your brain sends out muscular output, right, and your finger moves. Also, cars. We have cars now that know how to. They can stay in a lane now by using these systems. Mm-hmm. We know how to stay in a lane, yeah. And then they control, cruise control. So we're going to talk about a little about that, just to sort of show the examples. So again, regulation of physiological systems is usually aimed at maintaining a specific set point, like temperature or PCO2 or pH. So these are fast feedback systems, where like tonicity, where a specific number is desirable. You want your pH to be 7.40.
Right.
You want your PCO2 to be 40. You want your temperature to be 37.
These tightly regulated.
Very tight, and you want your tonicity to be 285.
And there's risks if these systems get out too far off.
That's right.
Yeah.
You can all die from all these cause death and quickly. So the fast feedback systems that really react quickly are the ones for a specific subject. And then there's the slower ones, like sodium homeostasis, where the constant level of the substance is the definition of steady state. Excretion rate equals the production rate. In the clearance flow talk, we talked about the derivation of that equation and how when those two sides are equal. And then talked about the twins and all that kind of stuff. So so these tend to be lower, less tightly regulated systems that are probably a little bit more complicated. So let's say you want to keep your car at 55 because it's illegal to go faster than 55, but you've got wind and hills and valleys. So homeostasis says that the velocity of the car remain constant despite variations in all these things. Steady state says the rate of acceleration is equal to the rate of friction, because friction is a negative acceleration. So your positive acceleration has to take care of that. So a feedback control system, which is your cruise control, is the difference between the desired speed and the actual speed, and that error signal is detected and corrected. And the difference,
clamping velocity.
And the difference between, I've been in cars with good cruise control and cars with bad cruise control. So somebody says, why is this Mercedes more than this Chevy? And the answer is that the cruise control in the Mercedes is almost imperceptible. As soon as there's an error signal, it reacts and it's smooth as scotch.
Right.
Okay? Smooth as single malt. And then, I'm not bad-mouthing Chevy.
As an example.
But an example is a car that's not expensive.
A cheaper version.
Yeah. You've been in cars where as you're climbing the hill, you can almost feel the jerking.
Right.
As the cruise control system is banging you around.
Right.
That's not smooth negative feedback control. It may not be what they call PID control or other better control systems. It's more bang, bang. Okay? And so...
Like a teenage driver.
So let's look at some feedback control systems. So when people talk about feedback, there's open loop feedback system. And an example of that, there's many, but an example of that would be an automatic toaster. It's automatic in the sense that you can set lighter to darker.
Right.
But
there's no feedback from the toast. Hey, I'm brown.
Exactly.
I'm perfect.
So you empirically figure out where does this little knob need to be to give you my toast. And then your kid wants a different kind of toast, moves the knob, and you don't know it.
And you got a burnt bagel the next day.
Exactly.
Come on.
So, the thickness of the bread, wherever the knob is, it's only good for that type and thickness of bread. Because if you change from that bread to a bagel, your heat may be off.
So the toaster, the classic open loop system.
Classic open loop. Because there's no feedback of toastedness.
Although there's probably, is there feedback on the temperature of the filaments, or just?
Yes, there is. It's just that. But but it's open loop for toasting.
It's open loop for toasting.
It's called a toaster, Craig. It's not called a heater. It's not called a heater.
Okay, you got me.
Craig, take your bread off your radiator.
All right.
Craig's got.
I'm ironing the grilled cheese again.
I stay overnight at Craig's house, and he says, "Here's some toast. Take it off the radiator."
I ironed this grilled cheese for you.
Exactly.
Right. Oh, that's so funny. Good. So that's open loop.
Yeah. Now, negative feedback examples. I put negative in green. Usually negative is a bad thing. Negative is a good thing. That's why it's in green. Driving down the curvy road, cruise control. An outfielder catching a fly ball. Now, you've played the outfield. These outfielders, they know from the crack of the bat where to run.
That's right.
And what do? They camp out. They run to where they are going to camp out. And then they camp out making slight corrections and adjustments until the distance between their glove and the ball is zero. Okay? And they catch the fly ball.
Perfect.
Okay.
Love it.
Positive feedback example, sneezing. Now, positive feedback is generally unstable. So it's used to make explosions, and these explosions serve a purpose. So sneezing serves a purpose. You more have to sneeze, and then you more have to sneeze, and then you more have to sneeze, and then you sneeze and it's gone.
Right.
So for a positive feedback system to work, it ramps itself up like that. But then after the explosion, the brakes are applied. So you don't keep sneezing forever.
Right.
Okay? So the sneeze is like that. Vomiting is like that. You got to get this stuff out.
Right.
projectile vomit, whatever. You got to get this stuff out, but then it has a natural break on itself. And parturition. You got to squeeze that baby out.
Right.
And, push, 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 push. But the doctor doesn't keep saying push, push, push.
Right.
Once the baby's out.
Right.
Okay. But so you need the contractions that are so unpleasant for a woman in delivering, painful. But it's positive feedback to expel something.
Right.
Get this foreign body out of here. Literally, it's a foreign body.
Right.
You're related to it. But the contractions are painful because it's positive feedback.
Right.
Okay. So that's feedback systems. So we've talked about negative versus positive. And negative feedback means the system response is opposite to the directions of perturbation. So if it's too hot in the room, the furnace kicks off. If it's
right.
So if you're going uphill, the car accelerates.
Right.
If you're going downhill, the car brakes.
Right.
So when the response is opposite to the directions of perturbation, that's negative feedback, and that's what it's cruise control. The positive feedback, the system responds in the same direction, like a contraction, or rich people get rich while poor get poorer. For physiological control systems, well, stress can be good or bad. We talked about stress a little bit. Let's talk about this now. So negative feedback is adaptive. I'm under a lot of pressure and have a lot to do. That'll increase your stress above baseline. I will take care of the first thing on my list as an adaptive strategy reducing stress. I completed the first task. Now I feel better as another adaptive response. So you can have negative feedback approaches to being under pressure or stress. Mm-hmm. What about positive feedback? That's maladaptive. I'm under a lot of pressure. Same statements. I'm under a lot of pressure. I have a lot to do. Increase in stress and anxiety above baseline. It's hopeless. I'll never get everything done. Poor strategic response. Unlikely to reduce the stress.
Right.
I'm paralyzed. Getting nothing done. And I'm going crazy. So, there's a saying, I forget who said it, but somebody smart said that, who was it? I can't remember, but it's easy to look up. Said that if you focus on the past, you'll have depression. If you focus on the future, you'll have anxiety. So if you not want to have depression or anxiety, stay in the present moment. Mm. Because by staying in the present moment, you'll neither be depressed about the past.
Sounds like the Dalai Lama or Thich Nhat Hanh or one of those guys.
It's somebody pretty big. Along those lines, obviously a philosopher, probably a nephrologist. But again, that's the thing. So whenever I tend to maybe feel like I might be feeling a little depressed, I go, you're thinking about the past. Or, anxiety. I'm thinking about the future. But if we're here doing a podcast.
Right.
We're in that moment.
moment.
We're in that moment. We're talking about the past and the future.
Right.
But we're not stressing about it.
Right.
And that's the flow state. The
flow
state.
I was just going to say
the flow state is to neither be in the past or the future, to be in the present. Right. There are always people who I have some friends like this, where every time they get a muscle pull or a headache, it's cancer.
Right. Yeah, they go right to
it's cancer.
Yeah.
Headaches are pretty common. It's
maladaptive responses.
And and I go, do you have cancer now? No. Are you thinking about the future? Yeah. Now that's what explains your anxiety.
Right. Mm-hmm.
Your anxiety is that, I had a bad childhood. Again, you can be depressed about it because it happened in the past. Everybody's got bad past. Everybody's going to die in the future.
That's a guarantee.
If you live every day of your life worrying about, is today going to be the day I die? So back to the Princess Bride. When Wesley is telling Buttercup the story about the Dread Pirate Roberts kidnapping him and taking him prisoner, he said every day the Dread Pirate Roberts would tell him every night, he'd say, I'll probably kill you tomorrow. I'll probably kill you tomorrow.
Right.
I'll probably kill you tomorrow. But in point of fact, Wesley never got killed. He was smart enough after Dread Pirate Roberts said, I'll probably kill you tomorrow, to not worry about it.
Today.
He lived in the moment, and he said, I had today. And I don't know what's going to happen, because maybe I'll wake up dead tomorrow before Dread Pirate Roberts can kill me. But that was, again, one of the many important lessons from The Princess Bride. The book said, life's not fair, love's not logical. A lot of good stuff there.
Love it.
And so you can have the stress can be good or bad, and the way you employ the feedback is either adaptive or maladaptive. And it's adaptive, it's negative feedback, which is good. And positive feedback is maladaptive. Now, here's a feedback system. So again, there's an engineer would look at a feedback system. You got the input. You've got something controlling it. There's some process you want to control, and there's a controller. So the control process could be toast, and the controller is the coils. And then what the toaster doesn't have is, here's a little feedback that tells you how toasted we are. So run this input, the heat, and tell us if are we at toasting level? Well, the feedback says we're not quite there, so keep going, keep going, keep going, keep going. Okay, now the feedback is telling us we're at our level of desired toastedness. And so the error sensor that's sensing the difference between how we like our toast and where the toast is, all of a sudden gets close to zero. Ding! Your toast is ready.
Right.
That's the basic elements of a negative feedback control system. Here's the negative. The feedback elements are feedback negative.
Mm-hmm.
Now, so touch a fixed point with the finger. Okay, there's the desired finger position. There's the actual finger position. And whatever the difference is the error signal. That goes to your afferents. You see that. It goes to your brain through the afferent input. The brain sends stimulus out to the muscles. The arm and muscle move until you're on the point.
Right.
Okay. So that's a perfect negative feedback system. So you're using your eyes to sense things and using your arms. And again, you got your afferents, like your eyes and your brain, and your efferents are your muscles. Okay. So how about the task of eating peas with a fork? See peas, pick up moving peas, because you know how the peas roll away from you?
Oh, yeah.
Okay. So you use feedback to kind of get that pea.
Right.
Okay. And so here's the closed loop system again, just to show you for reference. You see the peas, you get the peas that aren't moving, and then the ones that roll away from you, make that move, and then you bring the fork to your mouth without spilling the peas.
Mm-hmm.
Now,
or stabbing your cheek.
right. So a normal adult has an optive negative feedback control system and does well. A baby, have you ever had a baby, Craig?
Yes, I've had.
Okay. Have you ever had
never personally?
Have you ever had a mess in the kitchen because of the baby?
I've had a mess in the kitchen.
Okay. So have you ever tried to have a baby eat peas with a fork?
Oh, yes.
Okay.
Well, no, not with a fork.
Yeah, with a little, they'll see the peas, or a spoon. They'll see the peas, but they do not have the coordination to control the fork. So even though they have perfectly fine brain, they don't have the arm coordination to do it. That's a baby.
Right.
Now, an adult with blindness is an adult and has all sorts of great things, but he's lacking input. Your afferent limb has been cut. You don't know if you got the peas. You need some other way of telling, a braille way of telling you you got the peas. And an adult with Parkinson's is the opposite problem. They're seeing it just fine, but they can't stop the tremor. And so how frustrating is it to be? To not, a blind person obviously has to live with that frustration. A person with Parkinson's has to live with the fact that they can see those peas and they knew they could always do it. And now every time they get the peas and then on the way to their mouth, they can't do it. Their feedback system, so their disease, their disease is a broken feedback system. Okay, and that's why I just think when you were talking about it, the reason we're talking about this again to remind everybody is that we're talking about what are the controlling mechanisms for hypertension.
That's it.
And what are the things? And is it the signal?
This is setting up the arms so that we understand the pieces of the puzzle so that we can now apply it to blood pressure.
Exactly.
And the theories of hypertension.
Exactly. Now, I really want to talk about ventilation because it's going to come up to be important. Okay. Now, ventilation is a very fast negative feedback system. So the desired PCO2 is 40 millimeters of mercury. And when the actual PCO2 is 40 millimeters of mercury, there's no error. But when there is an error, sensors in the brainstem tell the brain to do something. And the thing it does is it tells you to ventilate using your respiratory muscles. So the signals are sent out to the muscles of the chest wall. Okay? That's ventilation. And when it's done enough, so if your PCO2 has gone up, then the system is going to go. If the PCO2 has gone down, the system's going to slow down until it gets back up again. And only when these two things are close is the system going to not have much of an error signal. But the moment later, there's an error signal again.
Right, exactly. It's just oscillating between these two points.
Exactly. So life depends on these feedback systems, and those feedback systems depend on there always being a constant error signal.
Right.
With the cruise control, you're not clamped at, even though you clamped at 55, you're not exactly 55 every moment.
Right.
You're 55.05.
Right. And it can apply different amounts.
Exactly.
Of feedback.
That's a gain. Yeah.
Right.
Yeah. So I want you to remember this because we're going to use the two systems that excrete stuff. The kidney excretes sodium. It's this natriuresis. We're talking about natriuresis. And the lungs excrete CO2. And we're going to come back to this analogy. So here's at rest. Your CO2 is normal at 40. And then you exercise, and your CO2 production goes up, so your PCO2 goes up, so you ventilate. Now, everybody knows when they climb steps, they're going to breathe harder. You're going to breathe harder because you're generating more PCO2, and you're going to breathe harder. But nobody breathes ahead of time.
Right.
Okay? Because what's the point? The point is not to anticipate it, be anxious.
Right. It's to respond to the feedback.
Let yourself respond to the feedback.
Sensors.
Exactly. Right. Now, what about a smoker? Smoker will get lung disease, and that will mean that they'll have a decrease in the functional ventilation because as the smoking destroys blood vessel or alveoli, the surface area for gas exchange goes down. So even though they can stay in steady state of having their CO2 excretion equal their CO2 production, they can't. At the
expense of a higher PCO2.
It's at the expense of a higher driving force.
Right.
So they're in a steady state, but it's an abnormal steady state. And since CO2 is a pressure, and since 50 is high, what is
hypertension?
It's hypertension.
That's awesome. Hypertension of CO2.
But in this hypertension system, what's the controller?
Well, the controller, the brain.
The brain is the controller.
What's sensing.
So the lungs are just the object.
Yes.
So if somebody said, even though the lungs are the excretory unit,
right,
you could say, the PCO2 goes up and the lungs sense it and get rid of it. That's not true.
Right.
It's not direct PCO2 to lungs. It's PCO2 to brainstem to lungs.
Yeah.
Okay. So the CO2esis or the capniaresis is mediated by brain.
Yes.
Okay. It's an abnormal steady state. It's a hypertension, and it's mediated by brain.
Okay.
So the new abnormal steady state is achieved, but at the price or the cost of a higher PCO2 in the steady state. So the CO2 excretion rate, again, matches the production rate, but it's made possible by that higher driving force. Okay. Now, given that background, if you will consider, if you're still willing to listen to anything I say.
I love it.
If you're willing to consider PCO2 capniaresis, so having a high PCO2, physiologically, if you go to the ICU and somebody's got a high PCO2, we call it hypercapnia.
Right.
That's the medical term for it. Hyper meaning high, and then capnia has got something to do with some way that it's carbia or capnia.
Right.
And carb is usually bicarbonate. So I always say capnia for CO2.
I do too.
Okay. So I'm going to now make up a new word. There's no such word as capniaresis.
It's a seagullism. You know I love seagullisms.
It's a seagullism. So I made this word up because, but it's to the same extent that the kidney has to do a natriuresis, which is sodium excretion, the lungs have to do a capniaresis. So the normal PCO2 is 40. And that's essentially equal to 5.3% of atmospheric pressure. 40 meaning atmospheric pressure is 760 millimeters of mercury, so 5.3% is 40. Now, what happens if you purposely have somebody breathe a 7.9% PCO2 environment? Their PCO2 is going to go up towards 60, and it's going to stay there. Now, they're healthy. They don't have bad surface area. They're just being exposed to this new perturbation. So the increase in PCO2 will be an increased driving force that stimulates them to ventilate back toward 40. That will be a pressure-capniaresis. The pressure went up.
Interesting.
The pressure went up, right?
Right.
And that pressure caused them to do more lungy things.
Ventilate.
And so they're having a pressure-capniaresis, and the gain of the system will determine how close it will get. So the gain, unlike electrical or engineering systems, the gain in physiological systems, for reasons I can't figure out for sure, the gain is defined as the correction over the error. So if the PCO2 recovers back to 42, then the correction from 60 to 42 is 18, and the error from their target is 2. So they would say the physiological gain is 9. However, if these healthy people were able to recover back to 40 on dot,
then it's 18 over
0.
Over 0.
No, it's 20 over 0.
Right, 20 over 0.
And the good news about, but you were right
Anything
the first
over
time.
0, it's infinite.
Because even a small number over 0 is infinite. And that's what you would call an infinite gain. So I don't know the answer to this. If I'm sure you could take people I know in the 50s did this. And I read the papers in the 50s. Elkington did a classic paper on this, exposing volunteers, meaning med students and themselves, to a 7.5% or 7.7% CO2 environment. And that's how they generated respiratory. They wanted to see the response to respiratory. So for respiratory alkalosis, they hyperventilated. And for respiratory acidosis, they went into a chamber or breathed this gas. But they were healthy. So they all developed the Pressure-Capniaresis. And I don't know how far they got back, but if they got back to 40, but my guess is they didn't get back all the way to 40. My guess is that they got back to 40 point something at the best. So the gain was high, but not infinity. Because the infinite gain is awfully hard.
Yeah.
Anything with infinity is hard. I mean, the richest person in the world doesn't have infinity dollars. Awful lot.
But not infinity.
Not infinity dollars. So I made this first ever, maybe, because it's made up, Pressure-Capniaresis function.
Okay.
I plotted the partial pressure of CO2 in millimeters of mercury versus the CO2 excretion by the lungs in millimoles per minute. So you can easily do a calculation that if the partial pressure of CO2 is 40, to stay in a steady state, you have to excrete 12 millimoles per minute. Because over the day, you make 15 to 20,000 millimoles of CO2. You got to get rid of it all. Okay. So again, this linear relationship shows that CO2 stores are linear, and they are. That as your partial pressure of CO2 goes up,
your excretion will go up, and it will drive you back
to keep you in the steady state. Right.
Right.
So the graph makes it if you're just looking at the graph makes it look like PCO2 is driving the lungs. The Pressure-Capniaresis function makes it look like all we need is PCO2 in lungs.
Right.
Do you see any brain on this slide?
There's no sensor there.
There's no brain on this slide.
Right.
And we know the brain is the sensor. So because of our previous knowledge that the brain is the sensors, brainstem is the sensors, we don't take this too seriously and say that the PCO2 is directly driving ventilation. Because we have prior knowledge.
It's right. It's
but
not
what
a
if we didn't?
PCO2 effect on the lung.
I'm going to ask you, Greg, what if we didn't? What if we didn't know about those brainstem sensors?
Yeah, we could probably think that the PCO2 is driving the lungs. It would be a hypothesis.
And driving the lungs and the muscles.
Right.
Okay. So that doesn't seem like a very likely thing. So you're going to say, oh, let's look further. Point is, what if it's hard to find? You might be thinking, oh, maybe there is a system where this controls that. And that's where we are in the kidney. That's where we're getting. So ventilation is driven by the chemoreceptors. So even though we can make the plot, you can plot anything versus anything. You know, of course, I plotted something about me versus something about me. I came out looking gorgeous.
But it doesn't make it causal.
I know. I was gorgeous. I was a very intensively and extremely handsome man. But it turned out not to be true. So even though we can make this plot, the association of CO2 excretion by the lungs is not directly caused by the PCO2. Now, this gets us into that. We talked about that being a hypertension. So PCO2 is a pressure. So patients with an elevated PCO2 in the steady state also have a form of hypertension.
Right.
The price of having CKD is analogous to the price of having CLD, namely a higher tension due to defective sodium handling. That leads to our real hypertension. But is there a brainstem in the middle, or is there not?
Question.
Okay?
Sensor question.
Sensor question. So CO2 sensitive CLD patients correspond. I'm going to show you this. This is, again, I'm not sure if I'm right about this, but this is my sense. CO2 sensitive CLD patients correspond to the sodium sensitive doll rats. Okay? They do fine on the low salt diet. They do fine on the low CO2 diet. But you raise their CO2 and these ones will get hypercapnic, the lung disease patients, and these rats will get hypertensive. And that turns out to be a rightward shift of the curve with a decreased slope. And you'll see what I mean later. Okay. Now, go back to the healthy volunteers. The healthy volunteers breathing the high CO2 act more like the resistant rats, because you put them on a high PCO2 diet, they can get themselves back, and they won't have a slope change. They'll have a rightward shift of the curve. And this is relevant because black people, we've known for many years, black people have more of a sodium sensitivity. So people always wondered when ACEs and ARBs came out, not black people did better on those drugs than black people because those drugs don't affect the salt sensitivity as much as a thiazide. So that's why a thiazide is a very important element for treating hypertension in somebody who may be salt sensitive.
One has an One has a gain system that can manage the perturbation, and the other one has an impaired
from disease.
And
that disease may be evident or not evident.
Right.
So when those guys in the old days say, with no other apparent cause,
right.
that they could see.
Because they didn't know about channels back then.
They were the drunk guy looking where the light was good.
Right, exactly.
Okay? So you got so I'm gonna show you what I mean by these curves. But we're going to see there's a difference between having renal vascular hypertension and hyperaldosteronism. So here was the big breakthrough. It was Guyton. Arthur C. Guyton. As I mentioned to you, had polio, wanted to be a surgeon, and then turned his attention and became a great physiologist. So there is a whole school called the Guytonian school of blood pressure, the Guytonian control of blood pressure. And its central pillar, or its central tenet, is that blood pressure is controlled by pressure-natriuresis. The system involves blood pressure and the kidney in a way where you have pressure-natriuresis with an infinite gain. Now, we already talked about infinite gain being kind of infinite anything being hard to achieve. So here's the same kind so here's a time course of different, this is from a science paper that reviewed a lot of his findings from 1991. Great paper. And this nice picture shows the time course of the different things, the different integrated systems designed at keeping track of volume or pressure. Okay. And what's first is the baroreceptors. Right. Now, baroreceptors were called baroreceptors because, they were thought that sense baro. But we now know that they're sensitive to shear and stress with piezo.
Stretch.
Okay? Yeah.
Yep.
So the baroreceptors and the chemoreceptors are fast, but they go away. Okay? Even stress, it goes up. But here's the thing. After all these cardiovascular neuro things are done, here's the red curve. The red curve is after about, within 4 hours, the system is engaged by the kidney, that over the next forever is the controller. And if you look, and I'll show you, it's very steep. And so this is Guyton's hypothesis that when all is said and done, it's the kidney. And that people that have essential hypertension have a problem with the pressure-natriuresis, that there's a shift in their pressure-natriuresis. Let me show you that.
Okay.
So before I do show you that, let's look at a couple of just stories. So here's a young scientist drawing conclusions from observations. The mentor and the mentee are standing on a mountain watching people slowly walking to the opening of a mountain below. They observe people walking in, but do not see anyone walking out. And the mentor asks the mentee to draw a conclusion. The mentee states, it must be a tunnel, because that explains all the available data. Okay? So the mentor says, go down and take a closer look. And he walks in and finds it's not a tunnel. It's a cave with a man-eating lion, which also explains all the data.
Right.
But it's a lot, this mentor may have thrown his mentee to the lions.
Right.
Did I do that to you?
No, you never threw me to the lions.
Never threw the lions. So again, here you're looking where the light is. Here you're looking and you find out reality is not what you thought it was.
Right.
That reminds me of something, Craig.
It does. Let's hear it.
It reminds me of Plato's analogy of the cave, or allegory of the cave. Yes. And here we're getting philosophical.
I love it.
So, shall I tell the story?
I didn't think you were going to do this. Yeah, I want to hear this story. I love it.
Okay. So here's the story. And the particulars about this are very important. So, what's going on, Craig?
Oh, we got a call? We got a caller.
Got a caller. It's Plato. Plato's going, what are you doing talking about me?
I love it.
So Plato, let me just tell you a little bit about Plato. So back in the day, there was Socrates. Socrates was Plato's mentor. Socrates told Plato about this. And then Socrates was killed. And the reason he was killed was because he was saying, whereas everybody was saying everything is determined by religion or whatnot, Socrates was interested in reality.
And the truth and justice.
Yeah, truth and justice. And it was not fitting well with the ongoing political situation where he lived in ancient Greece there. And when he came back and started teaching people like Plato, his stuff using the Socratic method. What method are you going to use, Socrates? Hey, Socrates, what method are you going to use?
Right.
I'm going to use something I call the Socratic method because I'm Socrates.
Right.
Okay. So he got killed, and he was found guilty by, I don't know, some panel of hundreds of men who decided this guy's dangerous. So in kind of memorial to Socrates, and Plato's greatest student may have been one of the greatest of all, Aristotle. Okay, he was pretty good. But it was really those generations. So Socrates was the mentor of Plato, whose most famous student was Aristotle. But Plato would tell of the story that
only in our blood pressure podcast do they get Plato's allegory of the cave.
Right.
I love it.
Right. Well, I hope, but to me, it fits. You'll see why it fits.
Oh, it's so great.
I think you'll see why it fits. So here's what Socrates told Plato, and Plato related.
Okay.
He said, let's say that people are born, and from the time they're born, they're in a cave, and they can't get out of the cave, and they're forced to look at a wall because they're chained up in a way that they only can see the wall. And then in the real outside world, there is a parade of shadows on the wall that they name. I'll name that a horse, but they're not real.
There are people in control of showing them certain things.
A certain thing. So there was the quote sun was a fire in the cave.
Right.
And the fire, the cave was pretty dark. And the fire made enough light to throw the shadows. And they formed these opinions, hypotheses. But this wasn't reality.
Right.
You see, it's not reality. And Socrates was saying everybody is born like this. And your goal is to get out of the cave.
Right.
So what he said is, here's what you see if you're just looking at the wall of shadows. So if you now take this rough ascent to knowledge, which is not easy, you got to get free of all of the preconceived notions. Then you have to take the journey to ascend to knowledge. And then when you get out, the real sun is there and it blinds you. So you're confused. It starts, your ascent to knowledge starts with confusion.
That's right. And it even starts the first minute they turn around and they see the light of the fire, and they see they see the actual carvings. And then they see from the carvings that, wait, the shadows I saw were just representations of these carvings. And then they get even more confused because then they see the sun and then they see real horse.
Yes. So now but after some time, you're right. So the confusion fades after some time. You get used to the light. Right. Getting used to the light. Come out of darkness and get used to the light. And then they see that's a real horse. And that's a real tree. And the light is from the real sun. And so what was an illusion in the cave becomes, through this experience and the transformation, what the world more really looks like. And so then this guy says, oh, I got to tell the others. And so he goes back down into the cave and he says, hey, guess what I found out? So when he gets to the cave, now the cave is dark for him. He's not used to the dark. Rhodopsin. And so he's confused again.
Right.
Because it's the opposite way of being confused, like you said. And then what happens, the tragedy, is that when he tells the other people who are still
staring at the shadows
and don't want to be free, this is their world, and they want it to be like this.
Right.
And when this guy comes back and tells them how it really is, they kill him.
Right.
This is how Socrates
died. And they
died.
tell people, anybody else comes up with a craziness like this guy,
it's going to happen to you.
You're going to die too.
So this was Plato's allegory to not only what Socrates had taught him, but also how Socrates met his end. Socrates had climbed that ascent to knowledge.
Right.
And was a great philosopher. And went back to tell the others who weren't wanting to hear it and killed them. So
I think it's important for me. I think this is great because a lot of times when we have these talks, I get confused, and they're complicated topics, and they're things people are still unraveling over time. And over the years, as we learn more and more, and we move through this ascent to knowledge, because our science gets better and our understanding gets deeper. Those periods of confusion are good.
Right.
They're important because they're part of your transition to understanding something.
And I think if Plato were here today, he's on the phone, if Plato were here today and seeing the COVID-19 pandemic situation, which has been hampered by not only a very tricky virus and a very lethal virus and a very contagious virus, but also everything with vaccines and the potential for misinformation and disinformation
about treatments.
Right. The people who there may be people or groups of people that want to stay chained in the cave.
Right. Yeah.
I think the one thing we can talk about is we don't recommend that anybody drink urine. Listen, we know about urine.
Right.
The kidney, you ask any dialysis patient why they feel miserable on dialysis, because the kidney is not getting rid of more than 50 toxins that it normally gets rid of. That's getting rid of it in the urine. You drink that back, the kidney's going to say, "What's it? I got rid of this already."
Right.
So I think we're clearly stating with no reservation whatsoever, urine is to be made by the kidney and flushed, not drunk.
Yes, that's true.
But there are things out there that are just absolutely strange, and
but I think it's important to listen to people who have novel ideas and are thinking outside of the box.
Right.
And even if things sound confusing to you,
it may be confusing because you're not getting used to the light.
Exactly.
Yeah. Yep. So we're going to come back to the Plato.
Okay.
So now with that in mind, now we have two things I have in mind. I showed you the Pressure-Capniaresis curve, where we all agreed it's not direct.
Right.
Okay. It goes through the brain. Okay. It's high CO2 sensed by the brain stem.
Triggers lung excretion of CO2.
Lungs are being controlled. But the controller
is not the PCO2.
Is the brain. The controller is the brain, and the controlled element is the lungs and respiratory muscle. So here's what Guyton said. It was brilliant work. He integrated a bunch of systems. This was back in the 60s.
Mm-hmm.
And what he did is, just like there were rats, the doll rats later on actually, that were salt insensitive and salt sensitive, he said, here's what's normal. He plotted arterial pressure versus natriuresis by the kidney. This is urine, okay? And what he found was that the normal, quote, renal curve, or the normal pressure-natriuresis curve, was an extremely steep curve that once you reach a certain threshold of arterial pressure, any small change in pressure would cause such a natriuresis as to bring you back. So if you all of a sudden took a high salt intake, 4 times normal or 3.5 times normal, if you're on the right curve, healthy curve, your blood pressure will change a tiny bit.
Excretion goes way
up. But he said two things. It will change it, but just this tiny delta P is directly driving the kidney. That's the hypothesis.
Right.
And he said, furthermore, there's 2 kinds of potential hypertension you can have. You can have a salt insensitive hypertension where your curve is shifted to the right.
But it keeps the same gain.
Keeps the same slope, right? Same gain. And this would be like a renovascular hypertension.
Mm-hmm.
Or you can have a salt-sensitive hypertension where you're not only shifted to the right, but you're also have a decreased slope because you're hyper-reabsorbing sodium. And you're therefore sodium sensitive. And this would be primary aldosteronism. So these are the 3 key curves to keep in mind. Black being the normal, red being shifted to the right, salt insensitive, but same slope, and salt sensitive. And then for the caparesis people, this is the normally healthy person in the regular environment. This is that same person in the high CO2 environment. They shift, but they have infinite gain. And then here's people who have some chronic lung disease.
Right.
So these are the same. These are analogous. Okay, and do you see that?
Yeah.
Yeah. So you see that. And so the whole point is that Guyton was saying 2 major things. One he was saying is, here's how it works, folks. Small changes in blood pressure directly work at the kidney and cause natriuresis. There's no intervening brain.
Exactly. Exactly. That's why I think the capniaresis example is so good, because it shows that you can be looking at a graph and the sensor is not shown.
This is the same graph as the capniaresis graph.
Exactly.
And the question is Guyton right? And this is causal? Or is it more like capniaresis? And the second thing Guyton explained was, and here's how I explain essential hypertension. You're still doing it, but you're shifted.
Right.
And maybe you're shifted because of kidney disease.
Mm-hmm.
Maybe you're shifted for a hormone. Maybe because you're just shifted because you're shifted. Okay. So intensive work went on in the field, as you saw from those publications. And there was a Guytonian school of thought. And since he wrote the physiology textbook, it became very widespread. So he was great, and he trained a lot of people, and they became disciples like Plato and Socrates. And so this was the party line. And if anybody, I wasn't around much, but this was what was being taught in med school. I mean, I got taught this in med school.
Well, the students were chained, staring at the back of the cave.
Right, well, the students are there chained, and the question is, are they getting the reality, or are they getting something that could be an illusion, could be a shadow, and but this was dogma.
But you could see that there's other hypotheses.
Right. Well, as an engineer who I wasn't familiar with many systems with an infinite gain.
Right.
Didn't have a stereo that had infinite gain. It went up to 10.
Right. And that was it. These amps go to 11, though.
Yeah, 11. So but this was it, and generations of medical students have been trained in this.
And the other thing is,
and
we measure arterial pressure.
Yeah.
But is that really...
We measure it because it's easy to measure.
Exactly.
But so it would be great if the thing that's easy to measure is the thing.
Right.
But I don't know. And I questioned it from way back when, and I was beaten down, Craig. My professors were having none of it. This is what the book says. The book is this. It's the book. And I never was comfortable. I accepted it.
And then
I
it's
always
funny
left
that
myself
the
open.
arterial pressure is on the x-axis.
Well,
also.
that's also a weird thing. But I was having trouble with a lot of things. That was one of them too that you said. But the whole point was, I said, okay, I'll accept this, and I'll certainly answer my board questions according to this.
Right.
Okay, because I know that's what you're looking for. But there was always a difference between. I always thought when I'm taking a test, do you want to win or do you want to be right? So to win, you have to say, I'll give you the answer I know you're looking for. It's not the same thing as saying, I think that's the right answer.
Right.
And I would put in the margin, I circled C, I know that's what you're looking for. By the way, my answer is D.
Right, exactly. Oh, good one. Good approach.
To whoever.
Yeah.
But this is, we leave the slide up for a while because you really got to drink this in.
Yeah, no, that
and put
is
it
key.
against the backdrop of the Capniaresis curve.
Yes.
And see that
we're missing something.
From the curves alone, the curves say I'm describing the same system. Capniaresis is not direct. Guyton says it's direct. Maybe it's true. Maybe the kidney doesn't talk to the brain. But this says the kidney's not talking to anything.
Right.
The pressure is not talking to anything. It's a direct to kidney. So here, Barry Brenner and Kimura did some great work on this. And in this 1997 paper, which is not so long ago, my son was born in 1997, so was
mine
yours,
too.
Right. So now we're at the birth year of our kids. And what they decided to do, here's the original Guyton curve from 1987, and it was called the renal output curve or the Pressure-Natriuresis curve. And, the equilibrium pressures when sodium excretion and sodium output are the same. But it was a curve. And what they argued was make it a line. Because if you make it a line, then you have a slope and an x-intercept. Not the y-intercept, but the x-intercept.
Right.
And that we'll be able to explain disease by changes in the slope or the intercept. So here was, so what they did was they said, eat more salt, get more higher pressure, and we'll see. And again, they made a line. Higher pressure gives you linear related to the more natriuresis. And the slope, well, let's say the intercept. This intercept was a blood pressure, an MAP about 104. Basically when you were excreting no salt, which is a little high, I think, for eating no salt. But they were making approximations.
Right.
And the slope was this number of 22. And saying, disease, we're not going to describe diseases by changing that interceptor slope. So what they did was renal vascular hypertension shifts the line to the right, but doesn't change the slope. So here they clipped a renal artery.
Right.
And they set up increased afferent arterial resistance as the main disease pathway here. And then when they fixed it, they got back here. So here was the animal before, here was the animal with the clip, and here's the animal with the clip unclipped. Okay? It was just a shift to the right. Here, they gave him elbow, or they made him have primary elbow. I don't remember how they did it. There's multiple ways to do this. DOCA and Aldo and who knows what. And they saw the same thing, a shift, but there was also a decrease in slope. And the reason, so there's the shift because of the increased efferent arterial resistance that got set up because it's going to contract against the higher pressures, but also because of the sodium reabsorption. And you know, we can't go into the details right now, but take my word for it, the sodium reabsorption decreases the slope. So these are two different diseases. So if you could just look, so what Brenner and Kojima were saying is that by looking at the pressure-natriuresis curve,
if you make it linear,
and you look at what happens to the x-intercept versus the x-intercept and or the slope, it can give you a different diagnosis.
Right. It tells you about salt sensitivity versus salt insensitive.
Exactly. This is a salt insensitive move.
Right.
This is a salt sensitive move.
Right.
Sodium sensitive move. Along with both. So this is, you know, these are different kinds of Dalrats. Okay. Now, here's my analogy for pressure-natriuresis if it's working like this. So again, you can have a tub of saline, and the saline level, let's say the set point is halfway. So I made these darker lines where it's halfway. And let's say you've got saline coming in at a certain rate, like you're eating. Okay. Potato chips, Doritos, you know, and you're drinking enough water to make that isotonic saline. And then you have a drain, and the level stays level when the inlet flow rate and the output flow rate are the same. But I added springs to the drain so that when the level falls below, the springs will close off the drain a little bit, so the level will act as a negative feedback. So this system will be a negative feedback system, and your level will go back up.
So you have a little floater in there that then drives the spring.
Well, the springs are driving this.
So it's based on the resistance of the hydrostatic pressure from the water.
There's a drain that's being forced open.
I got it.
Against the spring.
Yes.
By the pressure. So the pressure is driving the spring, driving the drain open.
Perfect.
And the counter pressure is the spring.
Okay.
And I made a special spring, and the special spring is at the perfect level you want. It's called normal.
Euvolemia.
The euvolemia. And eupressemia.
Eupressemia.
Okay. At that special point, the springs are open halfway.
Okay.
And the force is just right to have everything be perfect.
Yep.
So the springs have a linear spring constant.
Okay.
It's loaded to 50%.
Mm-hmm.
If the level in the tub increases, either because salt gets loaded or it stops excreting, then the drain will open linearly, and that will be a pressure-natriuresis.
Yeah. Perfect.
If the level in the tub decreases, bleeding or loss of fluid, then the drain closes linearly, and that's a pressure anti-natriuresis.
Yeah, and this is pressure-natriuresis.
This is pressure-natriuresis.
Direct.
So direct. So and look, if it comes back to the same level, the error is zero. It's got infinite gain.
Infinite gain.
So this is a picture
of an infinite gain system.
Of a system that's got pressure-natriuresis with infinite gain. And we can say there's no brain.
Correct.
But what there is, Craig, is
a spring-loaded excretion.
Something, it's not the same system. You can build the same system without the springs. It won't work.
Right. No, because your outflow doesn't change.
Right. You can have no springs, and we all have the shower where the shower goes, and if there's hair in the shower, it builds up. But that's not the same thing. So it'll reach a steady state.
Right.
But it won't be a pressure-natriuresis control system like this. So the fact that there's no brain here, but there are springs. And the question is, what do the springs represent? This represents the intake. This represents the steady state level or volume, pressure or volume. This represents the natriuresis.
But it also represents the sensor.
The springs.
Yeah, are the sensors.
And so the Guytonian model would say there are no springs because the kidney is doing all of it, the drain. Or maybe not. Maybe he's not saying that. Maybe he's saying, along with Brenner and Kimura, they're saying that no, the shift, if you stiffen the springs, you'll shift to the right. Because now the thing will want to be closed more and the level will go up. So it could be that modifications of the springs. So maybe Guyton is saying, we need these springs. Great. What are they? So the springs are the cave shadow. Craig, this is intake. This is the steady state level.
Yeah.
This is the quote, pressure, what are the springs? The brain? The lungs? The little pinky? What are the springs? The springs are the sensors.
Right.
Guyton, in his day, they were unknown. But interestingly, I think if I'm interpreting it right, Guyton, instead of interpreting, there are probably sensors and we're missing them.
Right.
He
didn't say that.
He said,
it's the pressure.
it's the pressure as a physical force.
Right.
Now, the pressure as a physical force, what is sensing it?
Yeah.
Okay? So let me just go on with this model. So it may be possible to propose a hypothesis that that unifies pressure-natriuresis and what I like to call volume-natriuresis, that really it's the ECF
That's
volume.
where I'm thinking that there's a floater in there. That's a sensing floater.
Right. So it turns out that we now know
like the old toilet, the back of the toilet.
The new toilet. My
Hey.
toilet's still like that. That's
They're all
by
still
the way,
like
the
that.
toilet, I have a thing on toilet flush. It's got every kind of feedback in it.
I love it.
Yeah.
Oh,
'Cause
good.
when
I
you
want to
flush-
see that.
When you flush, the start of the flush makes it finish. That's positive
right.
feedback, and the negative feedback stops the water.
Oh, we're definitely doing it.
The magical toilet flush.
Yes.
I'll do that for another
podcast.
time. We'll do a short one on the magical toilet flush.
You
That's
got
how
it.
I taught the students feedback. I said,
I
you all can study this at home. Take the top off your toilet.
So great.
And the toilet that never stops running, of course, there's always an error signal.
Yes.
So anyway, what we've talked about before and what you've recently reviewed was the Nobel Prize winning talk about piezo, and we love ion channels. And the piezo is located in vascular smooth muscle, and piezo is located in basolateral membranes of the epithelium. So let's have a hypothesis with the forming piezo in vascular and interstitial cells may mediate the pressure part, although it's still transduced via stretch. And trip channels, which we know sense flow, are doing the urine part. So if the spring is set to less than 50%, that'll give you essential hypertension. If the spring constant is stiffer, that will give you hyperaldo or renal vasculitis. Both of the above will fit the curve to the right, and something like Guytonian syndrome would do the opposite. So Guytonian syndrome is like being on a thiazide diuretic. And what Brenner and Kabira showed was that the primary aldo folks had a less steep slope.
Right, the slope.
The diuretics
down.
folks had a more steep slope. So they were in the right direction of salt sensitivity.
Mm-hmm.
So here's some interesting data from that was sent to me yesterday by Peter Bai. I hope I'm saying his name right. He's at the University of Southern Denmark. He's a retired professor now. And he spent his professional life looking at this stuff and argued for decades with the Guytonian people. He visited Jackson, Mississippi, and he told me that he's come to the point, they came to a point, a steady state, if you will, of agreeing to disagree. Jackson, Mississippi, it's pressure-natriuresis, it's infinite gain, and that's the way it is. And Peter said, well, he was kind of a volume-natriuresis guy.
Mm-hmm.
And I read one of his 2004 papers and was very happy because I said, is anybody talking about volume-natriuresis? And he was. But that was decades after this school had been established. And, this is the little...
That's it.
Yeah. But he
The
shared...
shadows are on the wall.
He shared with me a figure from one of his previous papers from 20 years ago.
Okay, let's
Look
see
at
what this
he,
shows.
and what are you saying it shows here?
Yeah, so as he gave saline...
And this is hypertonic saline.
Yeah, so 3% saline then?
Yeah.
Yeah, so as he gave saline,
Yeah.
it looks like the blood pressure, the mean arterial pressure went down.
Yes.
And the sodium excretion went up.
Well, so this is a pressure in the wrong direction natriuresis.
Right.
So how do you, so if these are the data.
This is
So there's two things about these data.
low pressure natriuresis.
Right. There's two things about these data. One,
The slope is opposite.
pressure natriuresis with an infinite slope can't explain these data.
Right.
And the only way the pressure could go down is if the natriuresis happened first.
Right.
So under the condition.
Because the pressure never even went up as if it was going to overshoot.
Right. So it could have been. That's why Peter argues that this is volume natriuresis. That the hypertonic saline being hypertonic caused ICF to come to ECF. So there was a shift
right.
from ICF to ECF, which was a volume change.
Right.
Now that volume change could have caused a pressure change, but it didn't.
Right.
Okay. So the volume change definitely occurred. You know that if you give somebody hypertonic something, you're going to dehydrate the ICF, and the ECF is going to get somewhat
expanded.
Expanded. It didn't translate into a higher pressure. or even staying the same pressure. It translated into a natriuresis. This argues strongly for volume natriuresis. So we have a David and Goliath here. I mean, Guyton and the group, and again, all due respect, it's fantastic work, and it could be right. I don't know. I don't know. But this piece of data is not explained by that hypothesis.
Yeah, and there are other hypotheses for his data. For him to make the explanation he's making, he doesn't have enough data there to make that.
Right. Remember,
it's like he's saying all the people walking into the tunnel.
Right. Remember, this experimental condition, the patients are getting hypertonic saline.
Right.
That's not the way it happens in life. If you eat a bag of Doritos, you're drinking a beer with it.
Right.
Okay. So your time being hypertonic is very small. And you could miss this. But he's forcing hypertonic saline in.
Mm.
And that should, everybody say, what
should
happens
raise
when you,
the pressure.
Everybody would say that.
Right.
But then there are the data.
I know. That's so amazing.
There's the data. So I think this is an important slide.
That is.
Okay. So let's now look whether the medications we use for blood pressure work along these similar lines, irrespective of the mechanism.
Okay.
Okay. And so this paper, which is recent, 5 years, how do antihypertensives work? And what they did in this paper, which I think was nice, was they took into consideration these things like afferent arterial resistance and natriuresis and sodium reabsorption. And they said, how do you classify the antihypertensives along the lines of these kind of curves? So here's what they did. This is what we've seen before. We see that when you go from the arteries to the veins, the mean arterial pressure drops. But what's nice about this little thing is in the part here that's driving GFR, we talked about this during the flow talk, you've got this big, huge filtrate, 180 liters a day, most of which, 99%, is reabsorbed in the peritubular capillaries on the low pressure side. And then there's the urine output. So this is 99%, this is 1%.
Right.
So this is, I like this. I thought this was clever that they put
everything in terms of the renal vasculature.
Yeah, I mean, here's the action.
Right.
Here's where the flow is going. So they didn't just plot pressure. They said, by the way, here's the flows.
Yeah, I love that.
So
that's nice.
Isn't that nice? So, and here they plotted again. Here now urinary sodium excretion rate. Now they plotted it back, different. Now there's urinary sodium excretion and mean arterial pressure. And again, what they show simply is if you give somebody, so I don't know what happened first here. If you give somebody more pressure, they excrete more salt. But if not, if they're on a diuretic, they do better. Or is this that they salt loaded them? I don't know. It doesn't matter, okay, because it's just a relationship. It's not cause and effect.
Right.
Now here's what happens. Here's a group of blood pressure medicines like the alpha blockers, clonidine, prazosin, some calcium channel blockers, and they put angiotensin receptor blockers here and thiazides here, and say what these are going to do because they're going to afferently vasodilate. And a lot of this is through
adenosine.
But again, sodium delivery to the macula densa goes up to the glomerular feedback, which squeeze.
Which then gives adenosine, right?
Right, but that squeezes.
Yeah.
So it doesn't dilate. So I'm a little confused by that. But anyway, just give them the benefit of the doubt and say, what's the reason I'm showing this? Because this is now the effect of afferent arterial dilators.
Okay.
That it will lower the pressure up to the glomerulus, and then everything else is the same. But again, thiazides and furosemide are going to change things here.
Right.
I don't get this. But anyway, this is what they show. Then there's the group 2 drugs, inhibitors of sodium reabsorption. Now, come on. Inhibitors of sodium reabsorption, I'm all for saying that some of these can do that. But
what did they pick here?
I don't know. So I'm just showing this is out there. It's a frontier.
Hey, man, frontier.
Okay, and they show that, because it's now, they lower pressure, but now it's changed because of what's happened to volume or something like that. And then they show both. So here is maybe whatever the confusion we have, let's just look at both because that's all that matters. So both, and again, I don't know how they categorize these, but both they say you get both effects. So here you're at a point where you've increased glomerular pressure compared to what you were at. So there's more of a GFR. Even though there's a lower pressure, there's more of a GFR. And I'm not sure, I really get it, but anyway, this is what they're saying is happening. And the point of this isn't that they're exactly correct, and I don't know if they are. The point of this is that our medications, and here's my review of it, that the medications that act by vasodilating the afferent arteriole are kind of being your salt insensitive, fixing people that have salt insensitive hypertension, fixing the salt insensitive rat or person. And in my mind, that's ARBs, calcium channel blockers, beta blockers, alpha blockers, declining.
Yep.
Okay. Inhibition of sodium reabsorption along the nephron, and this just changes the shift.
Right.
Here, you're going to get the shift and you're going to get the change in slope. And to me, that's all the natriuretics, the angiotensin mineralocorticoid receptor antagonists, and the SGL2 inhibitors. And then there's a combination of both. So this is what I take away from it. Okay. So again, there's confusion, I think, everywhere. Now, we talked about this at all Rick Lifton's group, the monogenetic forms of raising and lowering hypertension, all involve the kidney handling sodium, either intrinsically or through RAS, okay? And that all inherited and required forms of hypertension share changes in salt handling by the kidney. These are very slopey things.
Right.
These are the slopey things.
Yep.
And here again is the beautiful thing, and we've seen this before, I won't belabor it.
It's great.
So another important thing about disease is that in 2001, or 2003, it was a very important paper, I thought, in the New England Journal of Medicine that showed, it was a study done, I think, in Germany, that they took people that died in auto accidents who were healthy until they suddenly died. And on autopsy, they had a way of counting their nephrons. They used stereo microscopy and certain other kinds of techniques to be able to tell from the tissue how many nephrons there were in the kidney. And the important part of the study is that they because they knew all these victims, they age match and sex match the victims. And in the normal people had an average of 1.4 million nephrons in a kidney. Mm-hmm. Okay. And the people who had hypertension, and nothing else would look wrong with them.
Right.
Again, so nothing else looks wrong with you. But back in the day that they say that the original people that said you have high blood pressure with nothing else wrong with you, I don't think they were counting their nephrons.
Right. Yes.
I don't think they found those keys.
Yes.
Okay. But when you do, I think the last time I checked, 700,000 is half of 1.4 million.
For sure.
So if you're unlucky enough to not be born with enough nephrons, or what Barry Brenner would call the nephron endowment, the other thing they found is that the volume of the glomerulus was much bigger. So when you're born with enough nephrons,
it's the same reason is someone develops CKD, and as they go from 1,400 down to 700, yes. Well, it's just like the chronic lung disease.
Well, this is the whole
losing
point.
Alveoli.
This is the whole point. This is the point of saying maybe you're born. These people were born with their CKD.
Exactly.
Okay? And the thing is, whether you're born with CKD or you get there through life, yes, but it's the same, puts you in the same place.
Concept.
And what happened to those people, the people with less nephrons, had less nephrons for such a long time that they had glomerular hypertrophy. The glomeruli were big.
Right.
So their efferent arterial resistance was probably not normal. Okay, they had screwed up blood vessels. So this is important. And your point of whether you get there with CKD, whether you're born with all your nephrons and then get there through some disease process.
Or acquired.
This we'll see. We'll say, oh, you got hypertension because you had, that diabetes and all that stuff. We don't know about these people. These people were born without enough nephrons. And that's why when you transplant the kidney, we never transplant a small kidney into a large person.
Right.
We try to give them their nephrons.
The right number of nephrons.
Right number. So again, what does this tell you? It's another paper. I can't see this data.
High nephron endowment protects against salt-induced hypertension.
So that would be in my little model. More nephrons give you a looser spring. So that as soon as the pressure goes up, the spring gives way.
Right.
So what the data are showing here is essentially that, and this again goes along with pressure-natriuresis. It's just not telling you that's the mechanism. When you have more nephrons, as your blood pressure goes up, your sodium excretion goes up, and then if you've got like mutations or something like that, or less nephrons,
it doesn't respond.
Yeah. So yes, it's better to have more nephrons. That's the drain, and it's the spring. So I'm going to argue it's the spring. And so pressure-natriuresis needs the spring. What's controlling
the spring?
What's the spring?
Right.
What controls
What's
whether
the sensor?
What tells you whether the spring is stiffer, and what tells you where it's set?
Right, exactly.
And I'm going to get to that. So I just mentioned diabetes as the perfect positive feedback storm for all these bad things. Why?
In the tub analogy, the spring serves two purposes, because the spring is both the sensor and the effector.
It is correct. It's part of the. It's in the loop. It's the loop.
But it's two pieces of it.
It's two pieces of the loop because it is at the same time regulating the opening.
Yeah.
And
sensing the pressure.
Exactly.
And so, like in the lung analogy, the spring is both the brain sensing and the lung, the ventilatory muscles.
And the surface area of the lung. But there the spring is much more one-sided. There most of the spring is the brainstem.
Right.
I mean, I would say there, the brainstem's most of the spring.
It's most of the spring, but the lung ventilation is the excretion. So it's the change. The lung ventilation is the change in the size.
Right. Yes, that's part of the spring too. But when you're healthy,
yeah.
So if you got all your surface area and your muscles are good,
yeah,
all of the spring is in the brain.
Okay.
Because what's making that spring? Those people aren't brain damaged.
Right.
When you smoke or you have COPD. I would argue this, Craig. Okay. I'm glad you brought it up. It's one of the great reasons of talking to you like this, and obviously we can't plan this, which is why it's so great in the moment.
Yeah.
I would say, to explain, now that I've thought about it for a minute, I was going to say that the spring is all in the brain.
Okay.
And then when you develop lung disease, you get another spring that wasn't there.
Oh, okay.
Now you get another
that's fixing your excretion.
Another spring that's not listening as well. That's fighting another spring that's in the other direction of goodness. It's fighting the controller spring.
Okay.
It's like the toast thing.
Mm-hmm.
You got a little something caught in your filament, and now there's something's interfering with seeing the toastedness.
Okay.
And so it burns your toast.
Got you.
Yeah. So I would say that the springs are good analogies. And that's why I wanted to do it. And that's why but I would say, just to review, that the healthy person has all spring in the brainstem, and then another spring of disease fights it. Okay? So in diabetes, what you got is a whole perfect storm. You got microangiopathy killing off the blood vessels directly. Then you got inflammation set up, and then that sets up fibrosis and high blood pressure, and that makes all that worse. And then that kills off your little beautiful glomerulus. And so you get proteinuria.
Nephrons.
Yeah, you get proteinuria and endothelial disease. And if you have proteinuria and endothelial disease, the rest of your blood vessels are not happy. And you're retaining salt. And you got the nephrotic syndrome, for crying out loud. There's a vicious cycle. Second verse, same as the first. What do those people look like? They don't look like people that live long.
Right.
They look like rapid agers who have strokes, heart failure, CKD, dialysis, and early death. Have you ever seen a patient like this?
I've seen a couple.
Okay. So here we now get. So what we're gonna do now for people that are following along, I'm sure everybody's lost.
That's good. We're leaving the tunnel. It's the ascension to truth.
It doesn't matter, Craig. Everybody's lost, but nobody's watching.
Exactly. Don't worry about it. It's totally fine.
We sit here and we fantasize.
This is the best. We're gonna have 3 views.
One of our shadows is that people are watching.
That's right.
Even if you're watching this, if you started at the beginning, you're dead by now.
Oh yeah, they're gone.
We've been going for several weeks,
and no chapters in this one either. Oh yeah, you got to go straight
So what
through.
we're trying to do here is we've developed this hypertension model with the tub and the Capniaresis.
Right.
So the analogy, we got the allegory of the cave, and we're tying that into the analogy of the lung Capniaresis curve. And is that the same as pressure-natriuresis? Because that's not direct. Or is pressure-natriuresis direct and it's different? So we're developing some models with the tub and the springs. Right. And now we've gotten to the point. So we're developing some elements and we're asking, where's the sensor? And now we're going to talk about for a second how we've developed new techniques to use on people that take advantage of Ohm's law, things like that, that are giving us a piece of information we didn't have before to help guide management. So this is very 2022.
This is 2022.
Okay.
And this is country nephrology here.
So you tell me when to switch the slides, but you're going to explain.
No, yeah. So you wrote bioimpedance plethysmography, but I say impedance cardiogram or cardiography.
So wait a minute, doctor or country. Are you saying that this very technically advanced technique is something that you, the country doctor, has your hands on?
Yes. I actually have 2 of these. And these are... I was introduced to a couple of years ago, actually before the pandemic, And
I'm interviewing you now.
yes, I appreciate
Okay.
that. And, this is something from the standpoint of blood pressure management. One of the hard things, and you showed this in your earlier slides, is we don't do a good job managing it.
Right.
And why is that? We empirically try these medicines and we talk about which ones to use, and thiazides and vasodilators or ACE inhibitors.
But we're using measurements that are intrinsically flawed.
Right. We're using measurements that are intrinsically flawed. We have an exam that tells us a little something about volume, but nothing that tells us what's the phenotype of this hypertension.
Yeah, we don't really
Why
get
does this person?
the light's not on the keys.
We're talking about salt sensitivity, salt insensitivity, but
Okay.
when we manage people, we're not really
Okay,
understanding.
so big deal. This got invented. Why should I care?
Right. So if you can see here, what impedance cardiography does is it gives us an idea of the phenotype of why does someone have high blood pressure? Are they hyperdynamic, for instance? Is it related to from the cardiac system being their cardiac output being high?
Yeah.
Are they vasoconstricted? Is there something tightening their vessels? Non-salt sensitive type things, or are they volume overloaded?
Mm-hmm.
And this gives us an idea, and there's some good studies that validated this technique. And it is so simple. I have a little picture there on the bottom right that shows the little electrode on someone's left wrist, and then I put one on their right ankle, and then the picture above shows you how a high frequency, low amplitude voltage can be applied, and that gives rise to a current that goes through the path of least resistance, which is through the aorta and the vena cava, and then through some excellent algorithms that have gotten better and better over the years, we can get a stroke volume, cardiac output, cardiac index, total peripheral resistance, total body water, and then there are some measures of LV function too, which is also important because there's a couple of studies that show in even stage 1 hypertensive patients that you would normally just talk to about lifestyle. If they have high cardiac risk factors or indicators of LV dysfunction, you would start with medicines earlier in those people.
Okay, now you got me excited about this, but I'm going to say one thing.
Go ahead.
You've called it impedance cardiography. You know what I would call it?
Tell me.
Ohms volumography.
I like that.
Because ohms flowography, because you're getting cardiac output that's a flow.
Yes.
Okay, you're getting this is a volume.
Right.
This is a flow. This is ohmy.
Mm-hmm.
Okay, so the fact that it's called, I'm a little bit biased against calling it impedance cardiography.
Impedance is resistance.
It makes it sound, yes, that's good. I love the impedance part.
Yes,
it's the
okay.
cardiography part I'm not thrilled about.
Okay, well, let's get rid of it.
Because you know why?
Tell me.
Because it sounds then like
So
cardiologist.
cardiologist.
Well, yeah, it sounds like you're a nephrologist. This must have gone to the wrong address.
You're right.
Yeah. So again, it's impedance. It's impedance flowography. It's ohm flow. It's Ohm's law.
It is Ohm's law.
And Ohm's law is ours.
It is. It is. That's true. If you look at the little tracing there on the left, it shows the EKG because the machine does do this. It looks at EKG.
It's looking at the EKG, and what is this?
And then that is the actual current. That's what
the
it's
output.
measuring. That's the output from the system.
Okay,
so
and it runs that through an algorithm.
It runs that through an algorithm.
Okay, so now that's great. So what is this telling us?
So in this one, I just took this from an old study that showed
very old, 30 years.
30 years old, that showed us that there are these different phenotypes, and this shows you kind of two bimodal groups here, like two groups. One was a very hyperdynamic group, the smaller peak there with the high cardiac output, and then there were people with a normal cardiac output.
So you're saying these are people that these are people that have a diagnosis of essential hypertension?
These are all people with hypertension, but they kind of come out into two groups as far as
right. But is it a homogeneous group in terms of the only thing quote wrong with them
is hypertension?
Okay.
Yeah.
Okay. So and then this was 30 years ago, but it's only now in your clinic, and yet it seems to be giving us data that we used to depend on from a swan.
Well, I think, some of the key points from this slide were that to get these numbers like cardiac index or cardiac output, and a lot of us remember from the old days in the ICU when we did float swans and wedge people, these were major league invasive procedures we did to understand someone's pressure and to try to figure out why did they have a low blood pressure. In those settings, we use it for shock.
Right, but it was the reason we thought it was worth the invasiveness was we were getting flow data.
Right. No, that's true.
And the wedge pressure, we're getting two kinds of data: flow data like cardiac output, cardiac index, and pressure data when we stop flow.
And in hypertension, I tried to get set up in my office to do swans in the office, but I didn't get approved for that. So
this is so. How close do you or the field think this plethysmography gets to what we would get with an actual swan?
It's been validated against echo data. I'm not sure with swan numbers, but I know there's a lot of ICU use of the particular machine that I use as well.
Would you say that it would be more common to walk into an ICU and see one or not see one?
No, I would say it's probably more common not to see one.
Right.
For the moment.
So even though it's 30 years old, it still hasn't reached, it's still not prime time.
The algorithms have recently gotten a lot better.
And
so
this
as
is
our
AI,
computing gets better, this is AI. These things
Yeah.
are modeled with AI. They've gotten a lot better. And so I'm interested. I've used mine in the ICU once, and I'm interested in using it more in certain settings. But, in terms of dialysis,
how long does it take you to use it on a patient?
it is literally in the office. I have it here. It's 5 minutes.
Well,
My
I don't believe you. So so if you go through some data, I'm going to some proof of that.
All right.
So here is like you say, a single study.
Yeah, this
brings
was
us back to China.
2019. This is China meets Yale. This is a friend of yours. Is this one of the authors? Did you know here, Harlan?
Oh yeah, Harlan is a he's a famous cardiologist and epidemiologist, very active on Twitter.
Love it.
And he's an institution at Yale.
Well, anyway, I think this was a good study to just represent 2019, 102 adults. These people aged, ranged in age anywhere from 18 to 85. They all had hypertension, and they were either in a group of standard care or they were randomized to impedance cardiogram guided treatment.
Okay.
Where they used an algorithm, and then they just followed up in 3 months.
What happened?
Slide. And they basically categorized people into kind of 3 groups. Were they a high cardiac index? These are the hyperdynamic people in red. Were they vasoconstricted, which were the group in blue? And then in light blue, were they volume overloaded? And then based on these algorithms, they decided which medicine they'd use, whether they'd go with, for instance, beta blockers in people who were hyperdynamic, calcium channel blockers or RASi inhibitors in people who were vasoconstricted, or diuretics as their first choice.
Now, honestly speaking,
it's not combo therapy.
No, it's not combo therapy, but honestly speaking,
yeah.
Do you ever choose a beta blocker as a first choice nowadays?
It would be very rare, but it's
rare.
very impressive when you do, and I'm going to show you a tracing afterwards, but I'll show you tracing afterwards and we can talk about that. That's a good question. Go to the next slide. So when they did the 3-month follow-up, what they showed was there was a big difference when they used impedance cardiogram to direct their therapy. Blood pressures dropped 20 millimeters of mercury after 3 months in the group where they did ICG guided, and in the standard group, it dropped 12. So, it was definitely and that's been basically what some of the smaller studies showed as well. You get quicker, better blood pressure control. And I'll tell you a couple other reasons why I love using it. Switch the slide. This is a tracing I did yesterday.
Hold on a second.
I did this.
It says 1/18/2022.
And today's the 19th.
Yeah, boy, you really did do it yesterday. So this is really up to the minute.
This was up to the minute.
How long did this take?
I have a portable machine.
How long did it take?
I got called by a nurse to see a dialysis patient with high blood pressure.
Okay.
And I came to see her, and I quickly put 2 little electrodes on her while she's on dialysis. And she's laying back, very comfortable position, watching her TV, relaxed. And I got a blood pressure, I think, a 153/70. She'd been running in the 150s almost all the time. And I hooked her up to the machine, and there was a question of whether we should be taking off more fluid or not. And she was euvolemic on exam. She did not have any edema, lungs perfectly clear. And if you can see here, there's kind of
that's kind of a shadow in the cave.
That's kind of a shadow.
Yeah.
But if you look at, I highlighted the cardiac parameters there at the top. Those you can see are all in green.
Yep.
If you look at her vascular parameters.
And what does green mean? Green good?
Green is normal. Mm-hmm. So that's in the normal range.
Okay.
And if you look at the vascular resistance, the total peripheral resistance, those 2 were pretty high. One is the resistance and one is an index, which is corrected for, I believe, the cardiac index.
Right.
And then there's the volume, and you can see her volume. She comes up as
Wait a minute, you said she was euvolemic.
See that? By exam, but by impedance, she had a little extra fluid on.
Oh, so getting out of the cave.
That's it.
Right. So I love this because it's striking to me. First of all, you didn't call this patient out of a zillion because it was just, we talked about it yesterday and you did it yesterday.
Right.
What strikes me and gets me excited about this is, like you said, all the cardiac stuff is green.
Right.
And then clearly vascular and volume are red, not by a little. They're red.
Right.
So to me, this would say, okay, she's on dialysis, so I'm not surprised she's volume up.
Right.
And with what we know about storing sodium in other tissues like skin,
right,
and bone, It's possible. But so I'm going to take fluid off on dialysis. But first of all, does this tell you? Would you go as far to say that the red volume would make you lower her dry weight?
I asked her, number one, of any symptoms of low volume, like was she cramping, was she feeling nauseous after treatment, how was she feeling?
Right.
And my feeling is always get the volume right first. And this is my impression from clinician. You can tell me your experience.
Yeah.
But I always feel like volume first, diuretics, dialysis, get the volume down, and then add vasodilators. This lady was already on losartan, 100 BID.
I agree. As long as they're already on protective RAS inhibition.
She's on max RAS inhibitors.
So seeing these data, and again, taking the good history of any symptoms of
volume depletion.
Or effective volume depletion.
Yeah, exactly.
Functional volume.
Right.
I would want to. This would make me want to think about lowering your dry weight.
Right.
Target weight, and then the vascular part of this would influence me to make sure she's fully RASed.
Right. Fully RASed, and I added a calcium channel blocker. I mean, these are the things. So
exactly.
It's like, I mean, these. So you can see this has a phenotype to it.
Yeah.
We're talking about things that if we didn't do this, we would be guessing. Hey, let's lower the dry weight a half kilo. Let's add this.
And that's what we did do.
Right.
Didn't through your whole fellowship. All we did was guess.
That's it. And now I love my impedance cardiogram because my impedance cardiographer, my impedance plethysmographer. The reason I love it, I love showing this to the patient. I love circling those 2 red lines, and I love saying, look at this.
No, that's another feedback system.
It's amazing.
You get them on board.
They are so on board because when they see those 2 red lines, that means something to them.
It does.
And I circle all the green ones, and I say, your heart is great. This looks good. I circle the 2 volume ones, which are usually okay, and I say, look, your fluid's good. You're doing good with your sodium restriction and your diuretic. Your problem, your blood vessels are too tight.
Right.
You need more blood vessel loosening or vasodilators. And I see those 2 red lines. This is so meaningful
maybe that's
to
part
patients.
maybe that's part of the spring. Now, you could say the good news is your impedance plethysmography looks like Christmas. The bad news is it's got to be all green.
That's it.
Got to be all money.
And I do a lot of follow-ups. And one other thing about plethysmography, it's cheap.
Good.
So in terms of managing blood pressure, the bang for your buck using these, if you improve your blood pressure management, it's a big bang for your buck.
It is a big bang. And you've convinced me that this is an essential tool not only for your toolbox but for others.
But I think if you want to call yourself a hypertensive specialist,
yes,
this is now in our toolbox.
If you're a person who deals with complex hypertension,
this is important.
This is in your
I think
toolbox.
it's helpful.
So now let's get back to thanks for that excellent
I appreciate
review.
that.
I think
appreciate you letting me.
I think that was beautiful.
Talk about that.
So here is getting back toward the spring. We're still talking about what are the spring loading of that tub. What could be there? Because there's, like you said, the spring is 2 things. It's regulating the flow, and it is part of the sensor. So here's Piezos, and we talked about this, won the Nobel Prize, and you see the last author here is Artem Patapoutian, who won the Nobel Prize for Piezos. And this particular paper from Science, journal you never heard of, and just from a couple years ago, what do they show? They showed that stretch-sensitive baroreceptor neurons, and maybe this is a little bit of an oxymoron.
Right.
A stretch-sensitive pressure receptor.
Yeah, right, yeah.
But anyway,
they
said that they were mechanically activated and that both Piezo 1 and Piezo 2 are required. And they be very careful to say, remember, Guyton put this as the acute response, this ain't the kidney. The baroreceptor is acute. So in this neuroscience science paper, they are showing the sensing of blood pressure. And they say sensing of blood pressure. Okay, so that's important, not volume.
Right.
They're saying sensing of blood pressure. But don't forget, this is happening not at the kidney. So if it's going to affect pressure-natriuresis, it means this is something outside that. And what they showed here is they had some mutations. They had some animals that had mutations that rendered piezo not working.
Okay. And
they gave phenylephrine. And the normal thing, here's some sort of thing that represents neuroactivity. And basically, at this important aortic depressor nerve, by recording the nerve activity, they tell you what the baroreceptor quote is doing. So here's the blood pressure. When they add phenylnephrine, blood pressure goes up. And what you see over a short time course is easily you see more amplitude, and here's the integrated response. This happens. And then they give nitroprusside to dilate. And basically it reverses.
Signal
So
goes away.
this is signals that look like they have similar time courses and responding quickly to changes in pressure at the baroreceptor. And then give it to the mutant that doesn't have the piezo flat. Okay, so that was short term, and they were careful. I got to give it to them. Short-term blood pressure homeostasis. They didn't say this is the long-term because the baroreceptor is not the long-term.
They don't want to be killed.
They want to be killed. So now here is another Nobel Prize winner, Rod McKinnon, won the Nobel Prize in 2003 in chemistry for crystallizing the KCSA channel. He's very interested in piezo. He wants to know the mechanism. So what he says is, he says piezo is an ion channel that gets open when a force is applied. And it's this large ion channel with an unusual shape. You see, through membrane calculations, mechanical calculations, they showed how this thing has to deform in the membrane. It's all membrane delimited. Like
this thing's got like so many transmembrane segments, doesn't it? It's
a zillion. And so they conclude that it's changes in membrane tension, and the pushing on the membrane somehow. So here's kind of the picture. Here's this gigantic protein, and then from the top. And then somehow or other, but it's intrinsic to the membrane.
It's so space-time looking. I love it.
So the thing is that when you got two Nobel Prize winners saying the same thing, and you got mutations that back it up, but they're saying it's not the long term, but that doesn't mean it couldn't be involved in the long term. So one hypothesis.
Well, why are they not saying it's in the long term?
Because we know the baroreceptors. People that have baroreceptor dysfunction,
it doesn't persist.
They can. They
normalize.
They have their kidneys working, so they might have bigger swings, but their integrated response is still the kidney. Okay. I got patients with baroreceptor dysfunction. They're all over the place.
Yeah,
but their integrated response is still governed by the kidney.
Okay.
So you got two Nobel Prize winners telling us that piezo is doing this in the short-term response. That makes me say, pretty good chance they're involved in the long-term response. So maybe there's piezos in the kidney. Well, let's see.
I knew where you were going with this one.
Let's get to that. So here is before I show you that, I'm going to show you what Bernard Rossier, student of Izzy Edelman, talked about in the hypertension pandemic. It's again 1.2 billion people in the world, 7 billion people and 1.2. And here's what they say. They reiterate the fact. Here, I love this slide because he's showing that sodium intake changes blood pressure, but they sneak it through. It looks like volume's the transducer. So he's not actually saying, I don't believe in pressure-natriuresis. But he's saying
there's this volume change before it.
And so what you've got is, again, just like in the Lifton stuff, you've got the renin-angiotensin system. And they're saying, look, here's all the things involved. There's the brain, with some sort of neural output.
Yeah.
There's the kidney with its mechanisms, including maybe pressure-natriuresis. There's the adrenals, which have to do with angiotensin and aldosterone, which give you the resistance changes. And then there's, of course, pituitary responses, arteriolar direct responses. And that somehow, if you lower your sodium intake, blood volume goes down. That leads secondarily to lower blood pressure. Turns on the renin-angiotensin system. ECF volume goes up. And because volume goes up, ECF volume goes up.
This is volume-natriuresis.
This is volume-natriuresis. So I wanted to show you that he's talking about volume.
Volume.
So, and here's just a review slide that nicely dovetails what we talked about in the transport sessions. Includes SCL2 and their inhibitors in the proximal tubule, and even our Barter stuff in the calcium sensing receptor. This is a nice picture.
I love this slide. It's beautiful.
It just reviews what we've seen before.
Yeah.
But what about piezo along the urinary tract? What do we know about that? So again, these are recent data. So this is a study, came out in AJP Renal, where they raised enough signals against being able to identify piezo, and they did the whole urinary tract, from the afferent arterial to the urethra or something like that. So here's the afferent arterial, here's the urethra. My understanding of this slide is that wherever it's red, there's piezo. So piezo seems to be in the vascular smooth muscle of AA and EA. Okay, we're getting to the springs, Craig. AA, so it's the kidney, But remember, we said the
There's a
vessels,
sensor.
we said the vessels are on your way to the kidney, and that the glomerulus is in the kidney, but it's the vascular part. So we're getting to the sensors here. There's no accident that I don't think it's an accident that piezo is in the AA and EA. So my hypothesis is piezo may alter GFR by affecting the resistances. This would immediately give you those shifts.
Yep.
So this will give you the shift of
This is our
hypertension. This is the shift
like
spring.
trip warm and trip cold.
Yeah,
We've got piezo high and piezo low.
We got the shift spring. So one of the springs may be piezo shift. And look, piezo is also in the BLM of the tubule, where it may couple interstitial tension. Because interstitial tension, there's been correlations because you got that capsule that keeps the kidney together. Yeah. And the interstitial, if the kidney kind of swells a little bit, there'd be pressure put on. If piezo could sense that, then it could alter tubule transport. And again, we know that it changes transport elements. It's been shown by people that somehow things that, if you can show that interstitial pressure has gone up, suggesting that there's pressure volume overload, that sodium transport elements are downregulated. Okay? So the hypothesis is that the piezo in the blood vessels can change GFR through resistance and shift, and that the increased interstitial tension could also be sensed by piezo and affect pressure volume natriuresis through affecting sodium transport. I think these are the only data I know of that are showing piezo in the kidney, but it's telling us where it is and where it isn't. It is in the blood vessels of the vascular smooth muscle. It is in the BLM. It's not.
If it's there, what is it doing?
It's doing
Come
this.
on.
It's doing this. I think so. Notice it's not apical.
Right.
But what could be apical? So here's again my hypothesis. Piezo channels may alter GFR by affecting the resistances. Trip channels, the other Nobel Prize, David, this is Artem and David in one slide explaining
a Nobel Prize,
pressure.
BLM and apical.
Yeah, and explaining pressure. So this is why I call it a unifying hypothesis. Hypothesis because it's hypothesis. Unifying because I'm trying to bring this together.
Yeah.
And I'll show you my model at the end.
All right.
But let's just say the spring is that the components of the spring. So again, increased interstitial tension and urine flow lead to a decrease in apical reabsorption via piezo and trip channels respectively. These are the springs that mediate pressure volume natriuresis. That's where I'm coming to.
Got it.
And so here is my summary slide, if you're still alive.
Let's see.
So it goes over the two models we presented. On the top is pressure-Capniaresis again. That's in the rect. The partial pressure of CO2 goes up or down. It's sensed by the brainstem chemoreceptors, and then the effector is lung, get rid of it. There's no doubt that this is not red to blue.
Right.
The green is in between.
Yep.
Okay?
There's a sensor.
There's a sensor.
Step.
Now, the signal is pressure. The sensor is pH and CO2, chemical. So the pressure, I agree here. Red is the pressure signal. Green, in this case, is a CO2 pH sensor, chemical, that does it. Now, here's arterial. Arterial is a pressure just like CO2 is a pressure.
Yep.
Increased arterial pressure is hypertension. Guyton was telling us that there is a direct arrow between this red to blue. There is no green.
Right.
Now, we've mentioned that infinite gain is hard to swallow, although I'm not saying it doesn't exist. I'm just saying it's hard to swallow. And we mentioned that there ain't no brain that we know of between these two. And you can graph it. But we knew about these. So when we got this relationship,
it's the same
we knew
graph.
it would be this in the middle.
Right.
So here's the alternative to the Guyton. If you're a Guyton school and you're diehard Guyton, you're always going to be here. The question is, where are you in the cave? I mean, is this, knowing what we know now, I mean, it certainly wasn't the cave when they came up with it.
Right.
Okay. Knowing what we know now, here's the question. What's the cave? What's reality? A Guytonian will tell you this is reality. And there ain't nothing wrong with that. It's not my favorite. It doesn't explain Peter's data. It doesn't make engineering sense to me. I do believe you can use systems approach to come to that conclusion, but it reminds me of the mentee and the tunnel versus the line.
Exactly. You're missing other hypotheses.
Right.
And as we learn new things, you have to incorporate them into your model.
Right. So the what I'm saying is that maybe it goes like this, that maybe it's both. Arterial pressure has piezo as a pressure sensor that affects natriuresis on the basolateral membrane and in the blood vessels. And that arterial pressure using flow senses volume and trip channels, which are flow sensors, also contribute to the natriuresis. So here's definitely how the Capniaresis syndrome system works. And you have your choice. You can be Guytonian, you can work through here, you can work through here, or as I'm right now today, here's where I am. With all great respect to this and the importance of this,
Yeah.
I favor the above and below ground as both parts of the spring. So what I say is, and I'll get that at the end. So that's what I'm going to say, and I'll review that at the end. So where are we in finishing up now? Where are we in 2022 and beyond?
Okay.
So screening, we now know how to do, and bioimpedance plethysmography. And it would be a good idea to intervene as soon as blood pressure starts to rise. I don't know when mine did. Lifestyle, we talked about diet, exercise, no smoking, sodium intake less than 2 grams, 5 grams sodium chloride per day. Medications, the big ones, these are the ones. Thiazide's always going to be a cornerstone. ARBs, gotta love it. Finerenone has got anti-inflammatory properties and is going to be big. Calcium channel blockers are still in the armamentarium. Beta blockers are off my list, pretty much, unless there's an individual case. And then flozins are going to be big.
Right.
All of these are aimed at loosening the spring. So the way I think about all these medicines are spring looseners.
Yeah.
So that you can have a steady state at a lower pressure.
Yeah.
Or volume. And the target obviously is probably less than 120/80. And I believe if FDR had all these interventions, he'd still be president.
Yeah, I agree with that.
Okay. So where's the future? So the future is illustrated by this article. This is an excellent article. Imperceptible energy harvesting device and biomedical sensor based on ultra-flexible ferroelectric transducers and organic diodes. That's a big mouthful. What are they saying here? What they're saying here is they are between advances in material science and how we can make electrical components out of all sorts of stuff and new materials, we can have what's called wearables, where, and I think Daniel Kraft talked about this at the ASN, wearables. So can you wear something like this that can sense all sorts of signals? And it uses engineering techniques of, what does this one say? I can't read it.
That's an ultra-flexible harvesting circuit.
Okay, so ultra-flexible harvesting, so it can fit around stuff. And then this says ultra-flexible something else.
Ferroelectric polymer transducer.
Right, so it's picking up signals.
Okay.
And resistances and frequencies and voltages. And then there's this one. So there's all sorts of these materials.
Rectifiers and capacitors.
Yeah, you can make all these components out of these things. And you get signals out that you can then use with the AI software that are going to give you novel signals. So here's my point. Maybe blood pressure was always a shadow in the cave, Craig.
Yeah.
And this technology will give us real-time, continuous data on small signals. This is kind of like very localized impedance plethysmography.
It is. I mean, I was just thinking that. I'm like,
miniaturized. It's miniaturized, continuous, localized plethysmography. And what new signals might we discover? So my point is, the new signals we're going to discover, I'm going to predict. It's going to say that blood pressure, as great as it is
not.
And is, because it's easy to measure, was never the end all. It came on the scene late. It doesn't follow any of the clear engineering design. It's the exception to the sensor rule. Infinite gain is a tough one. Not saying it doesn't happen.
Yeah.
Infinite gain, not there's anything wrong with that.
Right.
But I believe that these new signals are going to give us the spring components. And so in the end, we're going to use this technology to modify how we not only treat people and measure and follow people with blood pressure issues, and reduce their disease burden, we are going to figure out the components of the spring. And, that looks like, so this is what I want to, we had a long discussion. Everybody's dead now.
What an awesome theory. And I love your hypothesis. And I think these are the questions. And look,
did we make it from ancient China? Did we make it from
we went from ancient China
to 2021
to 2022?
Yeah,
I mean, that was amazing. Right. Wow.
So what's your takeaway? Because this is a long one. What's your takeaway?
Well, first of all, I think pressure-natriuresis, that concept, I was exposed to it during fellowship, but I didn't really get that it was missing the sensor. I mean, that was an important feature that came along. And then your analogy to the pressure-capniaresis, that opened it up. And at first when you were going through it and I was thinking about it, I was like, I'm not sure this, it unraveled the whole thing.
Oh, good.
And then I also had recently watched the Piezo and the Trip Award for that Arvid and Dr. Julius won, and those they were super interesting. And I think you have to, incorporate those into your model. What do I take away? I take away that we still measure this blood pressure, and we still have these numbers.
We're still arguing about the numbers,
right? And we still argue about the numbers.
And, the thing that I'm going to interrupt you just to say that the thing about what you just said. The robust systems that nature's incorporated don't defy. If you're onto something important, then you're not arguing over two numbers for 100 years.
Right. You got it.
It's not it's not a way the system's is done. That tells you we're on the wrong track somehow.
Right.
Which is why I've always been a flow volume guy more than I've been a pressure guy. I love pressure. I love voltage. I love driving forces, but I love flow more.
Right. And I think these things will find its place. I think sometimes when we measure things more, and this was one of my worries even when I got the impedance cardiogram, was does it make you do things necessarily that might not improve? And that was Osler's question early on.
Yeah.
Look, a lot of these guys were like, don't treat blood pressure. It's important.
Well, they had no drugs.
On the flip side, we know from some things we did in dialysis when we would measure, that we could overtreat people with volume if we were looking.
What happened when we tried to put their hemoglobin back?
Exactly.
Yeah.
And so we learn things about this. So I think they find their place over time, but we have to be open to advancements.
Right.
And
so I have two last questions for you.
Let's hear it.
Do you think, three questions. Do you believe in the spring? The mechanism is somewhere in the spring, the sensing. And you even pointed out, you said the spring is two things.
I mean, it doesn't make any sense to me that it would be just pure pressure-natriuresis.
Right. So
there's too much complexity going on between sodium transport. All you have to do is watch the first few talks to realize that there's a lot else going on.
Okay, so the second question, you believe in the spring. The second question is, do you think there's a decent probability that Piezo and Trip, the two Nobel Prize winning channels this year, are part of the spring?
I think there's a high chance. I mean, I've patch clamped proximal tubular cells.
Yes.
I know these cells care about flow and stretch.
Okay, good.
And to think that that's not part of the signaling system,
it's hard.
Is hard.
Right, especially when there's part of a black box. And then the last question is, how does this fit into what we talked about with Plato? Who's still on the line. I feel bad for the guy.
Hold on. Oh, wait, Plato just called in. He wanted to ask you something.
How do you think it fits in with the allegory?
I think it fits in with the allegory because I think that for the most part, people who are going to be Guytonian are going to be very fixated, and it's hard for them to open up to a new concept. And I think
perhaps,
I think in terms of, what I take away from that story, I think it's part of my digesting these talks. I go through these periods of a little bit of confusion.
Exactly.
And then I come out of these little confused states and I feel a little bit closer to understanding something. And then it gets better and better. And each of these talks that you've given, and this is like reliving my fellowship, have helped me so much to understand these topics. That's why I love doing them. That's why I don't want you to forget about me when you move to Maine.
I won't forget it. But I mean, I think that, when you talk about the periods of confusion, people don't like to be uncomfortable. But what you have to help people understand is that if you're never uncomfortable, you never learn anything. And you have to be uncomfortable at times to push yourself to learn stuff and to make it make sense to you. I don't believe you can be really truly happy unless you've had some moments of depression to know how life can be and how to overcome adversity.
Yeah.
And I think that your confusion acts as a, there's a new term around these last few years called, being a disruptor. Now, I thought being a disruptor, I used to have to stand in the corner for being a disruptor.
Right, exactly.
Okay? And my parents get called to the principal's office because I was a disruptor. Now it's got a whole different meaning.
Yeah.
Disruptor now is we don't need this, this one way of thinking about it. We need to disrupt it a little bit. We need a perturbation.
Mm-hmm.
And so making new hypotheses, and I think what we try to do today is use philosophy and physiology to make new hypotheses that are testable.
Yeah.
And to make a new hypothesis that's not testable is not a very useful. But with this model that we're showing on the last slide here, look, if one of these arrows is correct, or if none of them are correct, hypotheses looking at these questions will get us closer to whatever is correct. So I don't know if in the end it'll turn out to be, like Einstein always gets proved right 100 years later, and people say, oh, he's right again. But he was a disruptor.
Right.
And so the question is, I believe that in 10, 15 years,
this is going to sort itself out.
We'll know. And the question is, in 10, 15 years, hopefully I'm still around, and I say, oh, you know what? Guyton was right all along. It's direct.
And that's fine.
That's fine. Or this other thing was correct. Or something new was correct.
Right.
I don't care.
Yeah.
I just want to be around to see what it is.
See.
Yeah, and to study it. But again, in people watching, some people, our one viewer, I want to speak to our one viewer, is we've talked about a lot of stuff before that's been, kind of concepts that are well established, and now we're just going. Whereas here we went a little bit out on a limb, and also to invite people to go back to the lab, either clinical lab or basic lab or thought experiment lab, and think about these questions and come up with a strategy for how to test some of these
hypotheses. How would you test to see if piezo is involved in natriuresis response? These are awesome. I mean, Alan, I can't thank you enough. Again, this was epic. I learned so much. I really appreciate it, and I know people out there are going to learn a lot from
our
this
one
talk.
person.
Yes, our one viewer.
Okay.
Awesome.
All right.
Great. Thanks, Alan.
You're welcome.
Great
Craig.
night.
Great.